Right, so a very good afternoon, everyone. Yes, so can you just quickly tell me, am I audible and visible to all of you? Yes, so am I audible and visible to all of you? All right, so I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this particular session, I'll be doing the quick revision for the FMG upcoming FMG exam, and this particular session will be also useful for the NEET PG exam as well. So in this session, what are the three topics which I'll be doing the quick revision is, so I'll be doing the quick revision of the neurology, the quick revision of the pulmonology, and as well as the gastroenterology. So in the previous part 1 and as well as part 2 sessions, I have covered the remaining topics. So those who did not watch them, so you can just watch them. They are just around 6 to 7 hours, which will be definitely useful for your upcoming FMG exam. And they will also be useful for your upcoming NEET PG exam as well. Okay. And immediately, yeah, this session will be there for around 3 hours. Okay. This session will be there for 3 hours. So 1 hour neurology, 1 hour pulmonology, and 1 hour gastroenterology. Or gastroenterology is like very little. So neurology, I'll try to take little more time. That is 1.5 hours, and pulmonology 1 hour, and gastroenterology half an hour. Okay. So totally the session will be there for nearly around 3 hours. Okay, right. So having said this, and those students who want the PDF of this particular session immediately after the class, you can just join in my Telegram channel. Just give me a minute. Just give me a minute. Right. So, yeah, so those students who want the PDF immediately after the class, you can just join my Telegram channel. There, you will have the availability of the PDF, and I'll be also sending the same PDF even on the Unacademy Telegram channel as well. Okay, right. Yes, Pickle, yes, I'll try to write with bold pen, the thick pen. Okay, right. So now let us start with the session. So the link for my Telegram channel is Medicine Made Easy by Dr. Rajesh Gubba. And if you are unable to join, you can just text me on my number, that is my WhatsApp number. So that is 9686241211. So if you text for the link, I'll just send you the link wherein you can join and download the PDF. Okay, right. So having said this, so let me just tell you a few points related to what is going on Unacademy. So Unacademy has come up with these NEET PG Vitals, where you have the availability of the recorded lectures or the recorded videos for comprehensive NEET PG preparation. And Unacademy also has come up with the Rankers batch, that is with mainly starting from the January 10th. And Unacademy also has come up with the combo course, like that is having both live plus recorded version. And lastly, Unacademy is coming up with an All India mock test that is being conducted on 22nd of January at 9 a.m. So you can utilize these services which are coming up in Unacademy. Right. Now let us start with the right. So let us start with the quick revision of the neurology session. Yeah, Pickle, actually, I was not having access to send the PDF on the Unacademy Telegram channel. So I have sent to the coordinator. So most probably the coordinators might be sending the PDF on Unacademy Telegram channel as well. Okay, right. Now let us start with the very important quick topic, that is the Guillain-Barré syndrome. So Guillain-Barré syndrome, first of all, you need to know that it is a demyelinating disorder of the peripheral nervous system. Right, it is not the demyelinating disorder of the central nervous system, it is a demyelinating disorder of the peripheral nervous system. And you need to know that what type of hypersensitivity reaction is your Guillain-Barré syndrome. So it's a delayed hypersensitivity reaction. That means the individual will have preceding gastrointestinal infection by Campylobacter jejuni or respiratory tract infection by viral infections, after almost 1 week to 10 days, the individual will develop this Guillain-Barré syndrome. So it's a delayed hypersensitivity reaction, which is nothing but type 4 hypersensitivity reaction. So now, what are the organisms? The organisms will be the Campylobacter jejuni, which will be causing the gastrointestinal infection. And we have the viral infections caused by your cytomegalovirus, Epstein-Barr virus, influenza, parainfluenza, causing respiratory tract infections, causing this Guillain-Barré syndrome. Now, what is the pathogenesis in case of Guillain-Barré syndrome? So what exactly happens is our immune system will produce antibodies against these organisms, and the antibodies which are being produced against these organisms will cause the demyelination. Okay, so that means they will come and attack the myelin sheath. So this we call it as molecular mimicry, or right, it is your autoimmunity. Right now, what is the earliest manifestation in patients with the Guillain-Barré syndrome? So the earliest manifestation will be the distal areflexia. So what is that particular reflex which is being lost? That is, the ankle jerk will be lost. That will be the earliest manifestation, that is distal areflexia. Now, what is the pattern of paralysis? The pattern of paralysis will be the ascending type of paralysis. Right, the pattern of paralysis will be ascending type of paralysis, and it is absolutely a flaccid paralysis where the tone of the muscle is completely lost. So initially the lower limbs will be paralyzed, later the trunk muscles, and then the upper limb muscles. So the individual will have flaccid quadriparesis. Now, in 5% of patients, there will be total motor paralysis. That means there will be paralysis of respiratory muscles also. So once there is paralysis of the respiratory muscles, the individual will develop respiratory failure. So what type of respiratory failure? It is a type 2 respiratory failure. Right, it is type 2 respiratory failure. Okay, yes, Billa. See, it is not type 2 hypersensitivity reaction. Right, it is not type 2 hypersensitivity reaction because it is not immediate. Like you take in case of type 2 hypersensitivity reaction, like what you have, it is cytotoxic mediated, which is an immediate event. But here it is not an immediate event. Okay, it occurs after 8 to 10 days of the antibody formation. So that is the reason why it's a delayed hypersensitivity reaction. Okay, and the type of respiratory failure will be type 2 respiratory failure, where the individual will have hypoxia and as well as the hypercarbia. And the next important question is regarding the cranial nerve. So like the cranial nerve which is being affected is there will be facial nerve involvement, and this facial nerve involvement will be bilateral facial nerve involvement will be there. And what type of paralysis will this be? It will be lower motor neuron type of the paralysis. Right, it is lower motor neuron type of paralysis. Okay, right. Now, what is the most common type of the Guillain-Barré syndrome? The most common type of the Guillain-Barré syndrome, can anyone answer this? This will be AIDP, that is acute inflammatory demyelinating polyneuropathy. That is the most common type of your Guillain-Barré syndrome. Now, you should know one of the very important variant of Guillain-Barré syndrome, that is called as Miller-Fisher syndrome. What is the important point in Miller-Fisher syndrome is that in case of Miller-Fisher syndrome, the cranial nerves are affected first. Now, what is the most common cranial nerve which is affected in the Miller-Fisher syndrome? That is a third cranial nerve. And in these patients with the Miller-Fisher syndrome, you have a triad. So what is a triad in Miller-Fisher syndrome? You need to remember this OAA. What is this OAA? OAA stands for ophthalmoplegia, areflexia, and ataxia. Right? Ophthalmoplegia, areflexia, and then ataxia. Okay. Now, in case of Miller-Fisher syndrome, what is the investigation of choice? The investigation of choice is the antibody. And in case of Miller-Fisher's, the antibody will be anti-GQ1 antibody. Then you should know what is the investigation of choice in case of the Guillain-Barré syndrome. In case of Guillain-Barré syndrome, the antibody, that is in case of acute inflammatory demyelinating polyneuropathy, the antibody will be anti-GM1 antibody. Right, anti-GM1 antibody. Then how do you treat these patients with the Guillain-Barré syndrome? So that what is the drug of choice? Please remember the steroids have no role in the treatment of Guillain-Barré syndrome. So the drug of choice will be intravenous immunoglobulin, and the other alternative treatment option is the plasmapheresis. So what this plasmapheresis will do? This plasmapheresis will filter the antibodies which are being present, and thereby the individual will recover from that flaccid paralysis. And you should know the important the CSF manifestation in patients with the Guillain-Barré syndrome. The CSF manifestation will be albuminocytological dissociation. Now, what is the differential diagnosis for albuminocytological dissociation? You also come across this in patients with the Freund syndrome. So this is about your Guillain-Barré syndrome just in 5 minutes. Okay. Now, I'll just show you one quick question related to the same GB syndrome, and then we'll move on to the next topic. Right. Answer this question. Conduction velocity of nerve is reduced in all of the following conditions except acute motor axonal neuropathy, acute inflammatory demyelinating polyneuropathy, hereditary sensory motor neuropathy, multifocal motor neuropathy. Right. So the answer is the A, that is acute motor axonal neuropathy. So in case of this axonal neuropathies, the conduction velocity of the nerve is not reduced. Whereas in case of AIDP, which is nothing but your Guillain-Barré syndrome, that is AIDP, which is the most common form, here the nerve conduction velocities will be reduced. Right, here the nerve conduction velocities will be reduced. So the answer is A here. Okay. Right. Now, after having discussed about the Guillain-Barré syndrome, which is an autoimmune disorder, now let me just move on to the discussion of Myasthenia Gravis, which is also an autoimmune disorder. So Myasthenia Gravis, if you see, it is a postsynaptic nerve terminal disorder. Right? It is a postsynaptic nerve terminal disorder. And what is it? It is an autoimmune disorder where the antibodies are formed against the NM receptors which are present on postsynaptic nerve terminal. And this Myasthenia gravis is mainly because of abnormality within the thymus gland. And what will be the thymic abnormality? The thymic abnormality will be in the form of thymic hyperplasia. Okay, it will be in the form of thymic hyperplasia. Almost 65% of patients, they will have thymic hyperplasia. And the other important thymic abnormality that can be there is thymoma. So thymic hyperplasia and thymoma, these are the important thymus gland abnormalities that are responsible for your Myasthenia gravis. Now, this Myasthenia gravis, it has an HLA association. So what is that HLA association? That is HLA B8 or HLA DRW3. So this is the HLA association in case of Myasthenia gravis. That means these individuals with HLA-B8 or HLA-DRW3, they are at increased risk of the Myasthenia gravis. Next, coming to the pathogenesis, as already I have said you, it is an autoimmunity where the antibody is formed against the NM receptors which are present on the postsynaptic nerve terminal. And one more important point you need to know is that Myasthenia gravis being an autoimmune disease, it is also associated with other autoimmune diseases. So what are those other autoimmune diseases that can be associated is Graves. It can be also associated with the rheumatoid arthritis, and it can also be associated with the systemic lupus erythematosus. Okay, all these autoimmune disorders, they are friends together. So if you are there, I will also be there along with you, and let us kill the patient. Okay, so that is what is the tendency of the autoimmune disorders. So your Myasthenia gravis is an autoimmune disorder. Now, what will be the earliest manifestation in patients with the Myasthenia gravis? The earliest manifestation in patients with Myasthenia gravis will be the ptosis. And this particular ptosis will be the asymmetrical ptosis. And these patients with Myasthenia gravis, they have this characteristic diurnal variation of the symptoms. What do you mean by this? Early in the morning, the individual will be absolutely normal, but as the day progresses, there will be increase in the severity of the symptoms. Okay, so the earliest manifestation will be in the form of ptosis, and subsequently they will have the other manifestations, that is weakness of the facial muscles and weakness of the other muscles of the body as well. Now, in these patients with Myasthenia gravis also, there is involvement of respiratory muscles causing respiratory muscle paralysis. So thereby the individual will develop type 2 respiratory failure. So Guillain-Barré syndrome and as well as Myasthenia gravis, due to respiratory muscle paralysis, there will be type 2 respiratory failure. Now, what do you understand by this word ocular Myasthenia gravis? The word ocular Myasthenia gravis means that there will be only ocular manifestations, right? There will be only ocular manifestations, and there is a triad in case of the ocular Myasthenia gravis. What is a triad in this? That is the development of ptosis, number 2, diplopia, right? Number 2, diplopia, and third important manifestation is orbicularis oculi weakness. And what is the investigation of choice in ocular Myasthenia gravis? In ocular Myasthenia gravis, the investigation of choice is the antibodies are slightly different, that is anti-MuSK antibodies. right? Anti-musk antibodies. Okay, so that will be your ocular myasthenia gravis, the antibodies. Yes, Akhil Raj Billa, I will be discussing the respiratory system also in this session. So there I will teach you all the types of respiratory failure. Just wait for some time. In the respiratory system, we will discuss all the types of respiratory failure. Okay, right. Now coming to the most sensitive test in patients with the myasthenia gravis, the most sensitive test will be single fiber electromyography. That will be the most sensitive test, and the sensitivity is almost 99%. But whereas about the antibodies are present only in 80% of patients, so sensitivity is only 80%. Okay, and now what is the drug of choice in patients with the mild myasthenia gravis? Drug of choice in case of mild myasthenia gravis, that will be physostigmine or the pyridostigmine. But whereas in case of the severe myasthenia gravis, then the drug of choice will be the steroids. You need to give the prednisolone. Okay, now what about the thymectomy? So thymectomy should be done in all the patients between the age group of 15 to 55 years, right? Thymectomy should be done in all the patients between 15 to 55 years. Then we have another neuromuscular junction disorder, that is Lambert-Eaton myasthenic syndrome. What is the difference between these two? So myasthenia gravis, it is a postsynaptic, whereas Lambert-Eaton myasthenic syndrome, it is a presynaptic nerve terminal junction disorder. Okay, so this is presynaptic. Now what is pathogenesis? Here also the antibody is being formed. So antibody, it is being formed against voltage gated calcium channels, right? Antibody is formed against the voltage gated calcium channels which are present on the presynaptic nerve terminal. So thereby what will happen? The acetylcholine is not released into the synapse. So there will be decrease in the quantity of the acetylcholine at the synapse in case of the Lambert-Eaton myasthenic syndrome. Whereas in myasthenia gravis, the quantity of acetylcholine at the level of synapse will be normal, but there will be decreased neuromuscular junction transmission in case of myasthenia gravis. Now, what are the first group of muscles which are affected in Lambert-Eaton myasthenic syndrome? That will be proximal muscles, right? That will be the proximal muscles of the lower limb. So proximal muscles of the lower limb are the one which are commonly affected in patients with Lambert-Eaton myasthenic syndrome. Then what will happen to the deep tendon reflexes? See, in myasthenia gravis, the deep tendon reflexes are intact, whereas here the deep tendon reflexes, they are depressed or completely absent. Then what is the most sensitive test in case of Lambert-Eaton myasthenic syndrome? The most sensitive test will be repetitive nerve stimulation test. Now what is this repetitive nerve stimulation test? There will be incremental response on repetitive nerve stimulation test. Okay, right? And the next is the antibodies which are formed against the voltage gated calcium channel. And what is a tumor? See, myasthenia gravis, it is associated with your thymic hyperplasia or thymoma, but whereas your Lambert-Eaton myasthenic syndrome, it is associated with small cell carcinoma of the lung, which is nothing but your oat cell carcinoma. Then what is the drug of choice in case of Lambert-Eaton myasthenic syndrome? Drug of choice will be 3,4-diaminopyrimidine. 3,4-diaminopyrimidine. So what it does, it blocks the potassium channels in distal motor terminals and thereby prolonging the depolarization. So because it is blocking the potassium channels and making the neuron into a state of depolarization, this will cause the excessive release of acetylcholine into the synapse. So that is about your Lambert-Eaton myasthenic syndrome, which is a presynaptic nerve terminal junction disorder. Okay, now, so because we are done with the discussion of this neuromuscular junction disorder, now let me show you the images of the myasthenia gravis. So the presentation will be in the form of asymmetrical ptosis, right? Now this is nothing but your sustained upgaze palsy, right? Sustained upgaze palsy. Now what is this sustained upgaze palsy? Initially the patient is presenting to you, he may not be having ptosis, but you keep an object above the eye and you ask the individual to look up continuously. Within 30 seconds there will be development of ptosis, and that is what is called as the sustained upgaze palsy. Okay, next, now you ask the individual of myasthenia gravis to smile. They will have an abnormal smile, and that abnormal smile is called as myasthenic snarl. It is called myasthenic snarl. Okay, next, the another important image based question is about the Endophonium test, which is also called tensilon test. So once you give this tensilon or Endophonium, the ptosis whichever is there will completely disappear. But what is the sensitivity of this Endophonium test? That is only 95%. But whenever you are doing this tensilon test or Endophonium test, you have to keep atropine ready, because this tensilon and hydrophonium will increase the acetylcholine levels, thereby causing bradycardia. So you have to keep atropine ready whenever you are doing this particular tensilon test. Okay, right. Now the another important test for myasthenia gravis is your ice pack test. So on application of the ice pack, you see here that there is ptosis. On application of the ice pack, the ptosis will disappear. That is what is called as the ice pack test. And what is the mechanism for that? Whenever you apply the ice pack, there is increased neuromuscular transmission, so thereby the ptosis will disappear. So this is about your the myasthenia gravis. Okay, now one quick clinical question related to the myasthenia gravis. Okay, anyone of you please answer? Yes. So the question is, complaining of ptosis, difficulty in chewing, and occasional difficulty in swallowing. There is no diplopia or visual loss. Asymmetrical ptosis, mild restriction of extraocular movement with finger abduction test up to 60 degrees. Nerve conduction studies shows decremental response in orbicularis only. Electroretinography shows myopathic pattern. Antibody, that is acetylcholine receptor antibody, is positive. What will be your diagnosis? Yeah, yes. You are expected to be asked like some clinical questions also, either in your FMG or NEET PG exam. So you should be able to answer this, right? Yes, Akila Raj, it is not your ocular myasthenia gravis. It is the generalized myasthenia gravis. Why? Because in ocular myasthenia gravis, what did we discuss? Like we have discussed that the individual will have only ocular manifestations. But if you observe here, the individual is also having difficulty in swallowing. There is also difficulty in chewing. These are not seen in case of your ocular myasthenia gravis. So the answer is the generalized myasthenia gravis. Okay, right. So having said this, the next important topic which we will take up for the quick revision is the aphasia. Okay, right. Now please answer this. Fluent aphasia with preserved comprehension and impaired repetition is seen in. So the next topic for the quick revision will be the aphasia. Yes. No, 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 no. It is not Wernicke's aphasia. It is conduction aphasia. In case of Wernicke's aphasia, the comprehension is lost. The comprehension is lost. So the answer is the conduction aphasia. Now, let me just do a quick recap of this, the aphasia. So, for an individual to develop aphasia, what is the blood vessel that has to be affected? That is left middle cerebral artery, right? That is left middle cerebral artery. Now in order to okay, and you should know the areas, Brodmann areas. Wernicke's area, it is area number 22, and Broca's area, it is present in area number 44 and as well as 45. So you take the Wernicke's area. Where is it present? It is present in the posterior superior temporal lobe. Whereas where is your Broca's area? It is present in the inferior frontal lobe. Okay, Wernicke's area, posterior superior temporal lobe, and inferior frontal lobe will be your Broca's area. Now you take the Wernicke's aphasia. What will be the features of the Wernicke's aphasia? In patients with Wernicke's aphasia, the individual will have normal fluency, right? Normal fluency. That means it is effluent aphasia. But what is being lost is the comprehension is being lost. Because the comprehension is being lost, the individual will have nonsensical speech, or the individual will speak completely empty, meaningless words. So that we call it as neologisms, right? That we call it as neologisms, where there is new word formation. Whereas you take Broca's aphasia, the fluency will be decreased because it is a motor area. And Wernicke's aphasia, what is another name of Wernicke's aphasia? It is also called sensory aphasia. Whereas Broca's aphasia, this is also called as the motor aphasia, where there will be decreased fluency. But how will be the comprehension? The comprehension will be spared. And will there be neologisms? There will be no neologisms. There will be no neologisms. So that is about your Broca's aphasia. Then coming to conduction aphasia. So conduction aphasia, why does it occur? That is mainly due to damage to the arcuate fibers. Right, mainly due to damage to the arcuate fibers, you get this conduction aphasia. And in these patients with the conduction aphasia, the comprehension will be spared. And what type of aphasia is this? It's a fluent aphasia, because the Broca's area is intact in conduction aphasia. So that is the reason why it is considered to be the fluent aphasia. Then what is the problem in this then? The problem is there will be impaired repetition. And what you have to know is that this particular process of repetition is being lost in all the three forms of aphasia: in Broca's aphasia, in conduction aphasia, globe, and as well as, right. So in all these, Wernicke's, Broca's, conduction, and global, in all the forms of aphasia, the repetition is being impaired. Then coming to global aphasia. What is global aphasia? Everything is lost. Comprehension is lost. Repetition is being lost. Fluency is also being lost. Everything is being lost in case of the global aphasia, right? Next. Now, which particular cerebral hemisphere, right, which particular cerebral hemisphere is being involved for the development of the aphasia? So it should be left cerebral hemisphere, that is a dominant lobe, and this Broca's area and as well as the Wernicke's area are present in the left cerebral hemisphere but not in the right cerebral hemisphere. Then coming to what are all the conditions where you have this fluent aphasia. So your conduction aphasia, it's a fluent aphasia, right? Then Wernicke's aphasia, that is also the fluent aphasia. Okay, so these two are your fluent aphasias, right? So this is about the quick recap of the topic, that is aphasia. So now if you see this question now, fluency is being preserved, comprehension is also being preserved, there is only impaired repetition. So where do you get this? You get this in case of conduction aphasia, right? Now we'll move on to the next topic. Okay, so a patient presents with recurrent episodes of sharp pain over the right cheek, and that is precipitated on chewing. Between the attack, the patient is otherwise normal. What do you think is the most probable diagnosis? What do you think is the most probable diagnosis? Yes. Okay. So this is a classical presentation that you will have in patients with the trigeminal neuralgia. Yes, very good. So it is a classical presentation in patients with a trigeminal neuralgia. So now this entire trigeminal neuralgia, let me just quickly recap in just 3 to 5 minutes. Now if the question is asked like what is the most common division which is affected in case of trigeminal neuralgia, you have three divisions: ophthalmic, maxillary, and as well as mandibular division. So which particular division is most commonly affected? That is the maxillary division is what is most commonly affected. Then followed by that, you will have the symptoms in the mandibular division. Then you will have the symptoms in the mandibular division. Now, what is the character of the pain in case of the trigeminal neuralgia? Please remember, it is a very sharp pain, right? It is an intense sharp pain and it's a superficial pain, or it will be the character of a stabbing pain, and this particular pain will be there only for a few seconds. Okay, now trigeminal neuralgia, which side it is more common, right? It is more common on the right side, and this particular trigeminal neuralgia pain, it is also associated with facial muscle spasms. So when it is associated with the facial muscle spasms, then we call it as the tic douloureux, right? We call it as tic douloureux. Okay, now in these patients with trigeminal neuralgia, you also have the autonomic symptoms. So what will be that autonomic symptoms? The autonomic symptoms will be the redness of the eye. There will be also lacrimation along with the symptoms of the trigeminal neuralgia. But these autonomic symptoms are present in which division more commonly? These autonomic symptoms are more common in ophthalmic division. Okay, so in ophthalmic division, that is the 5-1 division. So in ophthalmic division, your autonomic symptoms are very common. Then what is the etiology for development of trigeminal neuralgia? It is the compression of trigeminal nerve root. So once you clinically confirm it is trigeminal neuralgia, then you have to do MRI to look for what is the compressive lesion causing compression of the trigeminal nerve root. Then can anyone tell me what is the drug of choice for trigeminal neuralgia? Very good. So that will be carbamazepine, which is a drug of choice. And if the patient does not respond to carbamazepine, you can give the oxcarbamazepine. Then if the individual is refractory to carbamazepine and oxcarbamazepine, then what is the alternative drug? The alternative drug will be baclofen, which is a skeletal muscle relaxant, or the another anti-epileptic drug, that is lamotrigine, should be given. Okay, so these are the alternative drugs, that is baclofen and as well as the lamotrigine. Then what is the surgical treatment in trigeminal neuralgia? So it is basically a decompressive, it's a compressive lesion. So you need to do the microvascular decompression. right? You need to do microvascular decompression of the trigeminal nerve root. Or the other important treatment option that we have is the ablative procedure. What is that ablative procedure that you can do is rhizotomy, right? Rhizotomy. So rhizotomy, it has to be done with radio frequency ablation, okay, or radio frequency thermocoagulation. So that will be the surgical treatment that you will be doing in trigeminal neuralgia. Okay, so this finishes the topic of trigeminal neuralgia just within 3 to 5 minutes. Right now, please identify what exactly is the problem in this patient. Yes, please identify what exactly is the problem in this patient. Right, what cranial nerve disorder is there in this patient? Yes, which cranial nerve disorder is there in this patient? Right, very good, Amit. So it is a seventh cranial nerve palsy and it is lower motor neuron type of facial nerve palsy. One of the very important example for element type of facial nerve palsy will be the Bell's palsy. Right, will be the Bell's palsy. Okay, so now let us discuss the facial nerve disorder in just 5 minutes. Okay, now you take the Bell's palsy. So if you take this Bell's palsy, this is considered to be the most common cause of the element type of facial nerve palsy. This is considered to be the most common cause of element type of the facial nerve palsy. Now, how do you treat this Bell's palsy is a very, very important question. So the management of the Bell's palsy, for example, if the patient presents to you within 72 hours, then you can give steroid, that is prednisolone. So prednisolone can be given if the patient presents to you within 72 hours of onset of the Bell's palsy. And is there and what is the important etiology which is presumed it is of viral in origin? And but adding acyclovir, it does not give any benefit. And the other important treatment option is the eye care. Now, why is that eye care all that? Let me just show you this image and tell you. Okay, so what will be the features of your seventh nerve element palsy? So the ipsilateral, right, ipsilateral half of the face will be completely paralyzed, right? So you can see there is absence of the fold over the forehead and the individual is unable to close the eye. So this orbicularis oculi that is being paralyzed. Then the nasolabial fold is also lost. The angle whatever is there is being lost and the individual is unable to puff the mouth. So the entire half of the face will be completely paralyzed in case of the Bell's palsy. Now, let me just tell you some important syndromes related to your facial nerve palsy. See, one of the very important syndrome is the Rosenthal-Mellon syndrome. This Rosenthal-Mellon syndrome, it is characterized by a triad. What is the triad? Number one, there will be facial nerve palsy. Number two, if you observe the lips of these individuals, they are like swollen. And how will be the tongue of these individuals? The tongue will be the fissured tongue. Right, the tongue will be the fissured tongue. So these are the features of the Rosenthal-Mellon syndrome. Then what is your Ramsay-Hunt syndrome? Ramsay-Hunt syndrome, it is the herpes zoster infection of the geniculate ganglion, right? Herpes zoster infection of geniculate ganglion causing the facial nerve palsy. Right, then coming to your Mobius syndrome. In Mobius syndrome, there is congenital absence of, right, congenital absence of sixth and as well as the seventh cranial nerve nuclei, and thereby the individual will have inability to have the adequate eye movements because the sixth nerve will supply the lateral rectus. So once your sixth nerve is gone, so the eye movement control is being lost. Okay, and because the seventh nerve is gone, the facial expression is also being lost. And you take the etiologies that will be causing element palsy. Your Bell's palsy is the element palsy. Your Bell's palsy is an element palsy, right? And the other conditions where you can have the element palsy will be the Guillain-Barré syndrome. And in Guillain-Barré syndrome, it is bilateral facial nerve palsy will be there. Then what are the conditions where you have upper motor neuron type of facial nerve palsy? Upper motor neuron type, you have this in case of the motor neuron disease. So in motor neuron disease, right, so in motor neuron disease, you have upper motor neuron type of the facial nerve palsy. Now, in case of Bell's palsy, right, in case of the Bell's palsy, you should know what are the good prognostic signs and what are the poor prognostic signs. So what are the good prognostic signs? It is the preservation of the electromyographic responses. That will be the good prognostic sign. And what is a poor prognostic sign? The poor prognostic sign is the advanced age of the individual with Bell's palsy. It's a poor prognostic sign. Then presence of the hyperacusis, that is also a poor prognostic sign. And if there is complete facial palsy, right, if there is complete facial palsy, that is also a poor prognostic sign. So this is about your facial nerve palsy within just 4 to 5 minutes. Okay, right. Now after having discussed, so two important cranial nerve disorders are very important for your exam. One is trigeminal neuralgia and the other one is the facial nerve. Okay, right. Now yes, yes, Ash, Justin Bieber, like what he has developed? He has developed Ramsay Hunt or Rosenthal-Melkersen syndrome. Yes, right. Now let us move on to, yes, this is the very important image based question related to the Rosenthal-Melkersen syndrome. So I said you that there is a triad. So what is a triad in Melkerson's Rosenthal syndrome? Like you have the presence of the swollen lips. And how is the tongue in this individual? The tongue will be the fissured tongue. The tongue will be the fissured tongue, right? And there will be facial nerve palsy. Okay, there will be facial nerve palsy. Okay, so this is what is your Melkerson's Rosenthal syndrome. Yes, Justin Bieber, he had the Ramsay Hunt syndrome, right, where the herpes zoster infection of the geniculate ganglion. Next, then followed by that, the next important topic for the quick revision is the headache. So, like you should know what is the most common cause of the primary headache. The most common cause of the primary headache will be tension headache. Followed by this, the next important condition will be migraine. Followed by this, next important condition will be migraine. Then what is the most common cause of secondary headache? The most common cause of secondary headache will be the systemic infection. Okay, then you should know the common migraine and as well as the classic migraine. So common migraine is that where you have migraine but there is no aura. Then what is classic migraine? Classic migraine is that along with migraine you have the presence of the aura. And which is the most common form of the aura? The most common form of the aura will be the visual aura. Right, the most common form of the aura will be the visual aura. Now in case of this migraine, you have to know the description of the or character of the headache in case of migraine. Just remember this mnemonic, that is pound. So P stands for the character of the headache. It will be of pulsating in nature. Then this particular headache, it is on an average 1 day duration. So overall if you take, it is around 4 to 72 hours, but on average it will take 1 day duration. Mostly it is unilateral, and these individuals, they will have nausea. And what will be the character of the headache? It will be disabling in character, right, or throbbing type of headache, right, or throbbing type of headache. So now out of these 5, at least 4 are, if they are there, then we can consider it as migraine. And if the duration of the migraine, if the duration of migraine is more than 72 hours, we call it as status migrainosus. Right, we call it as status migrainosus. Okay, so this is about the description of the migraine. Now let me just discuss the other forms of or variants of migraine. So we have what is called retinal migraine. So retinal migraine, migraine with involvement of retinal circulation, right, where in these individuals there will be thrombosis of retinal artery, and because of which the patient will develop blindness. Okay, because of this the patient can develop the blindness, right. Next, now the other important point you need to know is, along with the blindness, the patient will have this migraine which is called as the retinal migraine. Okay, right. Now let me discuss about the basilar migraine. So basilar migraine is that along with migraine the individual will have prominent brainstem symptoms, right. The patient will have prominent brainstem symptoms. Okay, so that is what is your basilar migraine. So what will be the prominent brainstem symptoms? The individual can have vertigo, staggering, incoordination of the limbs, there will be dysarthria. So this will be the prominent brainstem symptoms. Now coming to hemiplegic migraine. So this hemiplegic migraine, it is a inherited disorder or inherited variant which is like autosomal dominant trait, and along with the migraine the individual will have unilateral paralysis. The patient will have unilateral paralysis. That is what is called as the hemiplegic migraine. Now you should know the treatment of this migraine. See, if the patient is having like mild to moderate attacks, then the drug that we give is the NSAIDs. But if the patient is having the severe acute attacks, then the drug of choice will be sumatriptan. Right, the drug of choice will be sumatriptan. Then at the same time, you should know what is the drug of choice for the status migrainosus. Yes, anyone of you, what is the drug of choice for status migrainosus? Yes, that will be prochlorperazine. Right, prochlorperazine is the drug of choice for status migrainosus. Then you should know about the cluster headache. So cluster headache is that which is very commonly seen in males rather than females, and in these patients with the cluster headache, you should know the attacks will be very severe attack. The headache will be non-throbbing and explosive in quality. But where will be the location of this headache? It is periorbital localization. Right, that will be unilateral, right, unilateral periorbital localization. The pain is felt in and around the eyes, and it is very intense, non-throbbing, explosive in quality, and the duration of the headache will be around 3 hours. And the episodes, there are many episodes in a day. That is the reason why it is called cluster headache. Then what is the drug of choice and what is the prophylaxis? See, what is the first line treatment in case of the cluster headache? The first line treatment is you need to give the high flow oxygen. You need to give almost 12 liters per minute. Then the drug of choice will be the same, that is the sumatriptan should be given. The alternative drugs will be gabapentin or pregabalin is given. Then what are the drugs which are given for prophylaxis? For prophylaxis we give a calcium channel blocker, that is verapamil. Right, that is verapamil. Okay, then coming to the tension headache. So tension headache, it is a dull in character, and it will be bilateral, and it is being present throughout the day, and it does not affect the routine activity of the patient. So this is about your tension headache. Right, now let me just show you a question. A woman has bilateral headache that worsens with emotional stress, and she has 2 children both doing badly in the school. What do you think is the diagnosis? Right, yes, what do you think is the diagnosis? So the answer here is the tension headache. So tension headache, what did I tell you? It's a bilateral, and it is associated with the emotional stress or the stress. So that what the patient is having is tension headache. Now let me just show you one more important question. A woman, a, sorry, a 22-year-old man presents with the history of headache for 6 months, which is mainly on the frontal region, occasionally associated with nausea. He has been taking paracetamol 3 grams per day, hydroxycodone 50 milligrams 3 times a day, aspirin 300 milligrams 3 times a day for headache, but only with temporary relief from the symptoms and no focal signs on the neurological examination. He also has history of depression and is on treatment for 2 years with paroxetine. Now, what is the diagnosis? Right, so we have MK answering the question correctly. Very good, MK. So the answer is the analgesic abuse headache. Okay, now what will be the points in favor of this analgesic abuse headache? See, the headache will be refractory to analgesics. The patient is taking paracetamol, patient is taking hydroxycodone, patient is taking aspirin, but there is temporary relief of headache. Okay, next, along with the headache, the individual will be having the anxiety or depression. Right, our patient is having the depression. Okay, so these are the points in favor of your analgesic abuse headache. So how do you treat this analgesic abuse headache? How do you treat this analgesic abuse headache? So how do you treat is you stop all the analgesics. You stop all the analgesics. Okay, so that will give relief in the individual. Next, so now after having discussed about the important topic, that is headache, now let me discuss the extrapyramidal disorder, and this particular extrapyramidal disorder will be the Parkinsonism. Right, first important Parkinsonism, subsequently I will tell you the others as well. Now if you take Parkinsonism, Parkinsonism, like what exactly happens, what is a biochemical abnormality? There will be decrease in the dopamine levels and there will be increase in the acetylcholine levels. Then when you are using the word primary Parkinsonism, the another name for primary Parkinsonism is, it is also called Parkinson's disease, or it is idiopathic Parkinsonism, right? And it occurs mainly due to gene mutation, that is Park gene. Can anyone tell me on which chromosome this Park gene is present? On which chromosome is the Park gene present? So this particular Park gene is present on the chromosome 1. It is present on chromosome 1. Okay, then coming to secondary Parkinsonism. Secondary Parkinsonism, what exactly is this? It is post-encephalitic, right? Secondary to encephalitis, if you develop this Parkinsonism, that is post-encephalitic Parkinsonism. Then we also have some toxins. What is this particular toxins? That is MPTP. What does this MPTP stand for? Methylphenyl tetrahydropyridine. That is called MPTP. And the other toxins that can cause the Parkinsonism is manganese and as well as the carbon monoxide. Yes, Ash, even drugs also. There are certain drugs which can induce Parkinsonism. Can anyone tell me what are those drugs? Yes, what are those drugs? These particular drugs, they include the metoclopramide, okay, so risperidone, then phenothiazines, then butyrofenones, okay, butyrofenones, alpha methyl dopa, and metoclopramide. So this is what is your secondary Parkinsonism. And Parkinsonism can also occur secondary to ischemia as well, that we call it as vascular Parkinsonism, and it can also occur secondary to tumors in the basal ganglia. Okay, so this is what is your secondary Parkinsonism. Then we also have some infections. What are the infections? Even your HIV, then the influenza can also cause the Parkinsonism. Then if the question is asked like, what is the earliest feature of Parkinsonism? Any one of you? Earliest feature of Parkinsonism. So the earliest feature of Parkinsonism will be tremors. And what type of tremors will this be? This will be the resting tremors. Right? Next to this resting tremors, you should know the triad. So what is a triad? This triad includes rigidity, then akinesia, then tremors. These tremors will be resting tremors. And what will happen to the postural reflexes? The postural reflexes are being lost. Once the postural reflexes are being lost, the individual will have the tendency to fall repeatedly. The individual will have tendency to fall repeatedly. Now if you take this rigidity, so what type of rigidity is that? So cogwheel rigidity is what that you see in the upper limb, whereas lead pipe rigidity is the one that you see in the lower limb. Now one important sign in Parkinsonism, that is Myerson sign. What is that Myerson sign? That is decreased blink on the glabellar tapping. So when you tap over the glabella, immediately there will be a blink. But whereas here, even on tapping the glabella, there is no blink. That is what is called Myerson sign. And why do you get this Myerson sign? That is because of stiffness of the eye muscles. Then what will be the characteristic gait? That is festinate gait, where the individual will have a stooped posture, short shuffling steps, and there will be difficulty in initiation of movements. That is what is your festinate gait. Then what is this wheelchair sign of Quinn? See, wheelchair sign of Quinn is that these patients at one point of time they are completely wheelchair bound. Why is that they are completely wheelchair bound? Because at one point of time the postural reflexes are completely lost, where the individual is unable to stand at all, and this is what is called as the wheelchair sign of Quinn. Next, you should know the inclusion bodies, right? You should know the inclusion bodies and what is the structure which is being degenerated. So the inclusion body that you have in patients with Parkinsonism will be the Levi body, right? So this is what is your, yes, so this is the stained portion, whatever is there, this is nothing but your Levi body. And where will be this Levi body? This Levi body will be present within the substantia nigra in Parkinson's disease. Now then followed by the inclusion body, right? Then followed by the inclusion body, the structure degenerated will be the substantia nigra. Now you should know what is a drug of choice. Yes, please tell me what is a drug that we will give in patients with the Parkinsonism. Yes, what is the first line drug? We have many drugs, but what is the first line drug? The first line drug will be levodopa. But which condition levodopa is contraindicated? In which condition levodopa is contraindicated? Where we give like dopamine agonists. First line drug will be levodopa only. Yes. So wherever the condition is, the individual is having involuntary movements, like levodopa is associated with levodopa induced dyskinesia. So where there is tendency of like dyskinesia or involuntary movement, then in the place of your levodopa, then you should give the dopamine agonist. And these particular dopamine agonists, we have like many drugs, like we have pramipexole, then we have like ropinirole, then pergolide, then we have rotigotin, then we have amantadine. So these are your the alternative drugs, but immediately the first line drug will be levodopa only. Then what about the surgical treatment? Can anyone tell me what is a surgical treatment in Parkinsonism? Yes, what is a surgical treatment in Parkinsonism? Surgical treatment will be deep brain stimulation. Now whenever you are doing this deep brain stimulation, where is that you will place the electrode? The electrode, it has to be placed within the subthalamic nucleus of the lice, or it has to be placed within the globus pallidus. Now why is that it has to be placed in the subthalamic nucleus or like globus pallidus? Is that because substantia nigra, which is being completely degenerated in Parkinsonism. So placing that in the substantia nigra will be of no use because it's completely degenerated. So you have to place that electrode within the subthalamic nucleus or within the globus pallidus. Okay, right. Now, then followed by that, you need to know the other important extrapyramidal disorders like athetosis. So what is this athetosis? It is a continuous writhing movement of the hand. It's a continuous writhing movement of the hand, arm, neck, and as well as face. Now, what is the structure which is being defective for the development of athetosis? That will be globus pallidus. Right, that will be globus pallidus. Okay, then hemibalismus. What is hemibalismus? It is like sudden flailing movement, right? It is sudden flailing movement of the entire limb, that is called hemibalismus. And the structure which is being defective for the development of hemibalismus will be subthalamic nucleus. Okay, then coming to chorea. So what is this chorea? It is like dancing movements, so where the individual will have flickering movements in hands, face, and other parts of the body. And where will be the site of lesion for the development of chorea? The site of lesion will be within the caudate nucleus and as well as putamen. Right, caudate nucleus and as well as putamen. Okay, so this is about quick recap of the extrapyramidal disorders, right? So now we are after having done with the extra. So how is the pace going on? Are you all people able to follow the pace with which I am going on? So do you want me to increase the speed or decrease the speed? Is everything fine? Okay, now you see this particular image. So in patients with Parkinsonism, when you do the biopsy of the basal ganglia, then what is that you will observe is there will be loss of the pigmented nerve cells. The loss of the pigmented nerve cells. So you can see this is a normal substantia nigra, but if you see here, there is loss of the pigmented cells within the Parkinsonism, right? You see here, there is loss of pigmentation. Now, please answer this question quickly. Right, two patients in the neurology department were asked to draw concentric circles inside the red reference line. Which of the two patients is likely to be suffering from the essential tremors? Any one of you, quickly, please. Right, so yes, not both, not both. So it is the patient B has the essential tremors. Patient B has the essential tremors. Now, see, what are these essential tremors? Essential tremors are those which are like high frequency tremors. Okay, they are the high frequency tremors which significantly distorts the fine movements. See, and now in between your A and B, which particular patient is having the high frequency tremors? That is the patient B. whereas Parkinsonism tremors are just only 4 to 6 hertz. Only 4 to 6 hertz. Which one? The Parkinsonism tremors. But whereas your essential tremors, the frequency is around 10 to 12 hertz. So the answer is B. The answer is B. Okay, so Parkinsonism, low frequency tremors, whereas essential tremors, high frequency tremors. Okay, so we are done with the typical Parkinsonism. Whatever we have discussed until now is the typical Parkinsonism. Now let me just quickly recap the atypical Parkinsonism. Atypical Parkinsonism. So there are three conditions which I'll discuss. We have many others, but three important conditions. That is your progressive supranuclear palsy, Scheidegger syndrome, and as well as the Huntington's chorea or Huntington's disease. Now, but what exactly you mean by this word, the atypical Parkinsonism? Atypical Parkinsonism means along with the features of Parkinsonism, the patient will also have dementia. The patient will also have the cognitive defect. The patient will also have the cognitive defect, and there will be also damage to the cranial nerve. There will be also damage to the cranial nerve. So that is what is your atypical Parkinsonism, or we call it as Parkinson plus syndrome, right? Where along with the features of Parkinsonism, the individual will have additional features as well. Now, so one of the very important Parkinson's plus condition is progressive supranuclear palsy. In progressive supranuclear palsy, there is damage to the basal ganglia. Along with the damage to the basal ganglia, even the superior colliculus is also involved. Now, because the superior colliculus is involved, the vertical gaze of the patient, right? The vertical gaze of the patient is being lost. Because the vertical gaze of the patient is being lost, the patient will have recurrent falls. The patient will have recurrent falls. Okay. Now, electrooculogram is very important in case of progressive supranuclear palsy. What is that electrooculogram? That is, they will have the presence of the square wave jerks. Right? Presence of the square wave jerks. Where do you have square root sign? Where do you have square root sign in cardiology? Where do you have square root sign in cardiology? Any one of you? So electrooculogram shows square wave jerks, but where you have square root sign in cardiology? Yes, square root sign. Square root sign is a characteristic feature in patients with the constrictive pericarditis. In constrictive pericarditis, you have the square root sign. Okay, right. Whereas square wave jerks are seen in patients with the progressive supranuclear palsy. Now, what does the MRI show? The MRI show the characteristic hummingbird appearance. Right, will show characteristic hummingbird appearance, and these patients with progressive supranuclear palsy, they have poor response to levodopa. So in case of progressive supranuclear palsy, the treatment that you can give is the amantadine. Right, the treatment that you have to give is amantadine. So amantadine is helpful, and let me just show you this hummingbird sign. So this is what is the hummingbird appearance. Okay, where you have degeneration of the basal ganglia and as well as the superior colliculus as well. Right, now after having discussed about the progressive supranuclear palsy, now let me discuss about the Scheidegger syndrome. See, Scheidegger syndrome, the another name for it is the multiple system atrophy. Right, multiple system atrophy. And in this individual, if there is involvement of cerebellum, if there is involvement of cerebellum, then we call it as MSAC. Right, MSAC, that is multiple system atrophy cerebellar symptoms. Okay, now what will be these features of your MSAC? Because the cerebellum is the one which is required for maintenance of the balance. So once that is being lost, the individual will have gait ataxia, and the patient will also have tremors. And what are the tremors here? The intentional tremors. Okay, then what will be the MRI finding in patients with the Scheidegger syndrome? So we call this as the classical hot cross bun sign. Right, hot cross bun sign. And how do you treat this MSA? That is by your levodopa. That is by your levodopa. Okay, so that is about your MRI in patients with the multiple system atrophy. Then coming to the Huntington's chorea. Before that, you see this hot cross bun sign. Yeah, so this is what is the hot cross bun sign. Okay, right. Then next, after having discussed about the multiple system atrophy, now let me take up the discussion of the next important atypical Parkinsonism, that is the Huntington's chorea. So Huntington's chorea, the type of inheritance is the autosomal dominant type of inheritance, right? And what is the gene that is being mutated? The gene which is being mutated is the Huntington gene that is being mutated. And what is the type of mutation? It's a trinucleotide repeat. And what is a trinucleotide repeat? That is CAG repeat. Okay. Then what is the protein which is accumulated because of this Huntington gene mutation? So the protein that will be accumulated is ubiquitin. Right, the protein which is being defective is the ubiquitin that keeps on accumulating. Now you should know that these patients will finally have neuronal death resulting in dementia. So dementia is a characteristic feature in patients with a Huntington's chorea. Right, now what will the MRI show in these patients? Right, what will the MRI show? The MRI will show you the presence of the boxcar ventricle. The MRI will show you the presence of boxcar ventricle. Now let me just show you the MRI here. So this is a characteristic boxcar ventricle in patients with the Huntington's chorea. Now in these patients with the Huntington's chorea, how do you treat these patients? See, in these patients the dopamine is excessive, so because the dopamine is being excessive in Huntington's chorea, levodopa is contraindicated. So you should give, so levodopa is contraindicated. So you should give a dopamine depleter, and that dopamine depleter will be tetrabenazine. Right, that will be tetrabenazine. Okay, so this is about your atypical Parkinsonism. So please remember Shy-Drager syndrome, Huntington's chorea, and as well as the progressive supranuclear palsy. Right, now you just answer this question quickly, a clinical question, because the upcoming exams we are expected to have the clinical questions. Yes, please answer this. So a 59-year-old man presents with 9 months history of slow walking and dizziness on standing. This point is very, very important. Dizziness on standing. On further questioning, he had erectile dysfunction for the last 3 years. On examination, he has jerky postural tremors. This jerky postural tremors is also very important. So now tell me, what is the likely diagnosis in this patient? Yes, what is the likely diagnosis in this patient? Yes, quickly. So please remember, the individual is having dizziness on standing. The individual is having the postural tremors. That means there is involvement of the cerebellum. So that is nothing but your, I'm sorry, one second. There is involvement of the cerebellum. So that is nothing but your MSAC. Right, that is multiple system atrophy, that is cerebellar type. So why is that? Dizziness, that is one of the feature of the cerebellar involvement. Postural tremors, that is intentional tremors, that is also the feature of your cerebellar involvement. Now can anyone tell me why there is erectile dysfunction in this patient? Can anyone tell me why there is erectile dysfunction in this patient? Yes, quickly. Because these patients with Parkinsonism, they also have autonomic insufficiency. Right, they also have autonomic insufficiency. So as a part of autonomic insufficiency, there can be the erectile dysfunction. Yes, Rahul, what is atrophied, Rahul? Huh? Right, so erectile dysfunction is due to autonomic insufficiency here. Right, okay, so we are done with the atypical Parkinsonism story and the extrapyramidal and as pyramidal disorder. Right, so now we'll move on to the infectious pathologies. Right, we'll come on to the infectious pathologies of the neurology. So the infectious pathology is the meningitis. So meningitis, what exactly happens here? Meningitis, it is the accumulation of the inflammatory material in the subarachnoid space. In accumulation of the inflammatory material in the subarachnoid space. Now what is the most common organism that is responsible for the community acquired pneumonia? That will be strep pneumonia. Right, that will be the strep pneumonia. Now what is the organism that is responsible for post meningitis deafness? Post meningitis deafness, please remember the organism is the Haemophilus influenza. right? Then what is the most common organism causing meningitis in neonates? That will be the group B streptococci, right? Group B streptococci. Whereas in India, what is the most common organism in India? That will be Klebsiella, right? That will be the Klebsiella in India. Then followed by that Escherichia coli. Now, what will be the classical presentation in patients with the meningitis? So you have a triad of manifestations. What will be that? These individuals, they will have a very high grade fever and they will have headache with projectile vomiting, right? They'll have headache with projectile vomiting and they will have neck stiffness. What do you understand by the word projectile vomiting? Okay, so, right. Yes, thank you very much. Right. So yes, what do you mean by the word projectile vomiting? Right. Okay. So, what are the signs that will be positive in this individual? The signs that will be positive in this individual will be Kernick sign, then Brudzinski sign. Right, then Brudzinski sign. So what do you understand by the word projectile vomiting? Very good, Amit. Without nausea, if there is vomiting, that is called as the projectile vomiting. Okay, right. So these are the two important signs that will be positive. One is Kernick sign and Brudzinski sign. So what is Kernick sign? The patient should be made to lie in the supine position with hip flexed, and in this individual the knee, right, in this individual the knee cannot be fully extended. That is what is called Kernick sign. Then what is Brudzinski sign? You do passive flexion of the neck. When you do the passive flexion of the neck, automatically the legs, they get flexed. Automatically the thigh and as well as the legs, they get flexed. Okay, so that is what is called as the Brudzinski sign, or the Brudzinski sign and as well as the Kernick sign. Then you should know about the investigations in patients with the uh, meningitis. So that is lumbar puncture. So in which particular space, in which particular intervertebral space you do this lumbar puncture? Lumbar puncture, it is being done in between L3 and as well as L4. L3 and as well as L4. Then what is the name of the needle? The name of the needle will be the Quincke's needle, right? The name of the needle will be Quincke's needle, or we have another important needle which is also called as the Sprott's needle. And whenever you are removing the CSF, what is how much amount of the CSF you have to remove? You have to remove nearly around 20 to 30 ml of the CSF. And what is the rate of production of CSF? The rate of production of CSF will be around 20 ml per hour. The CSF will be continuously producing by the choroid villi which is present within the ventricle. And what is the total amount of the CSF which is present in the subarachnoid space? That will be around 150 ml. Now, what is the sequence of the workup that you have to do in this patient? So, first and foremost, what you have to advise in this individual is take the blood culture, then give empirical antibiotic, then do a CT scan, then you can plan for the lumbar puncture. Okay, then you can plan for the lumbar puncture. So this will be the sequence of the workup in patients with the meningitis. Now coming to the complications. So what is a very very important complication that you should be very much worried is about the hydrocephalus, right? And whenever the individual develops hydrocephalus, the treatment that you have to do is VP shunt, ventriculoperitoneal shunt. Now let me show you that needle and as well as the CSF analysis quickly. Right, so this is the needle. So what is this particular needle here? This is your Quincke's needle, and we have one more needle. This is what is nothing but your Sprott's needle. So Quincke's and as well as Sprott's. Now what is very important in the meningitis that you should not miss, that is about the CSF analysis, right? So if you want to know the CSF analysis of abnormal, you should know the first CSF analysis of the normal. So you take the normal CSF pressure, that is around 50 to 80 millimeters of water, and the color of the CSF will be completely clear like water. The number of cells will be 0 to 4 cells per cubic millimeter, and that too which cells will be there? That is mainly lymphocytes. And how much will be the normal CSF sugar? That will be 2/3 of the plasma sugar. And how much will be the CSF proteins? That will be 15 to 45 milligrams percentage. Right now, in all the forms of meningitis, what will happen to the CSF pressure? The CSF pressure will be elevated in all the forms of meningitis. Then you take acute bacterial meningitis. How will be the color of it? It will be turbid in color. Why is that it is turbid in color? Because there is accumulation of the inflammatory material in the CSF. That is the reason why the turbid color will be appeared. Then the cells, if you take, more than 1000 cells will be there per cubic millimeter, and these particular cells are mainly neutrophilic predominant. And what will happen to the glucose? The glucose levels will be reduced. Why? Because the bacteria will utilize the glucose for the survival. So the sugars will be reduced. And what will happen to the protein levels? The CSF protein levels will be elevated. Why? Because the antibodies are formed against this bacteria, and antibodies are nothing but the proteins. Now, and what is the empirical treatment in acute bacterial meningitis? Empirical treatment that you will be giving is the ceftriaxone. And that too you have to give 2 grams of ceftriaxone. And to this, you can also add vancomycin. To this, you can also add vancomycin. So that is about your acute bacterial meningitis. Now coming to tubercular meningitis. So tubercular meningitis, what will be the color of the CSF is? It is like straw colored CSF. And how many cells will be there? More than 100 cells will be there per cubic millimeter. And that too, what are those cells? It is mainly lymphocytic predominant. The glucose may be utilized by the tuberculous organism for the growth. So the CSF glucose will be reduced. And CSF protein also will be elevated in case of the tubercular meningitis. Okay, so this is about your TBM. And what is the treatment in TBM? That is, anti-tubercular therapy should be given for nearly around 6 to 8 months. Next, then followed by that viral meningitis. So in viral meningitis, the color of the CSF will be clear. Then what are the cells in the CSF? That will be lymphocytes. That is, more than 25 cells per cubic millimeter will be there, and that too they are mainly lymphocytic predominant. Sugars will be normal, but the proteins will be elevated. And in case of the viral meningitis, like the antiviral drug that you can give is the acyclovir, or depending upon the viral agent, you can give that particular antiviral drug. Then coming to fungal meningitis. Fungal meningitis, it is very common in immunocompromised patients like HIV. And what is the organism mainly? That is Cryptococcus meningitis. And in these individuals, how will be the color of the CSF? That will be absolutely clear. There is no problem. And the cells, there will be nearly around 25 to 500 lymphocytes per cubic millimeter. And the sugars will be low. The glucose is utilized by the Cryptococcus neoformans or Cryptococcus meningitis. The glucose levels will be low. And protein levels, either they are normal or elevated. Right? Protein levels, either they are normal or elevated in patients with the fungal meningitis. Okay, and in case of fungal meningitis, what is the drug that you will give? That is amphotericin B. Right, and at the time of discharge you can give the fluconazole. Okay, so that is about your fungal meningitis. Now you take the Guillain-Barré syndrome. We were discussing this in the Guillain-Barré syndrome itself. So the CSF pressure will be normal, color will be normal, cells will be normal, glucose will be normal, but albuminocytological dissociation will be there. Albuminocytological dissociation will be there. And what is the differential diagnosis for albuminocytological dissociation? What is the differential diagnosis for albuminocytological dissociation? That already I have mentioned. What is that? So the differential diagnosis for albuminocytological dissociation is Freund syndrome. Freund syndrome. Okay, right. Now coming to the next important investigation. Right. So please identify what is exactly the abnormality within the test tube here where the CSF have been collected. And this can be asked as one of the image based question. So what is there here? This will be your cobweb coagulum. This will be the cobweb coagulum. Okay, so this is about your, and one more important image related to meningitis that you need to know is about this rich focus. Now what do you understand by this word rich focus? So actually this has been given by a pathologist, right? So that is the name given as the rich focus, and it is basically a tuberculous granuloma. And this tuberculous granuloma, it is occurring within the cortex or meninges of the brain. And this granuloma, it ruptures into the subarachnoid space. Once it ruptures into the subarachnoid space, the individual develops tuberculous meningitis. And that is what is nothing but your rich focus. Okay, right. So this completes the discussion of your topic of the meningitis. Now, Okay. Now motor neuron disease. So motor neuron disease, just 3 to 5 minutes, I'll finish the motor neuron disease. So motor neuron disease, as the word itself tells you, that there will be only motor manifestations, right? Only motor manifestations. Now, what is the most common type of motor neuron disease? The most common type of motor neuron disease will be amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis, you have both upper motor neuron and as well as the lower motor neuron involvement will be there, right? Whereas, which is that motor neuron disease where you have primarily lower motor neuron type of paralysis? That will be spinomuscular atrophy. That will be lower motor neuron type of paralysis. Now, what is that motor neuron disease where there is primarily upper motor neuron type? That will be primary lateral sclerosis, where it will be primary upper motor neuron type of paralysis. Okay, then what about sensory manifestations? Never, right? Sensory manifestations will never be there in motor neuron disease. Bladder and bowel involvement will never be there in patients with the motor neuron disease. Please remember this. No bladder and bowel involvement, no sensory involvement. Now, what is the risk factor for the development of motor neuron disease? The risk factor will be smoking, right? Smoking. Yes, Alex, the important person or the important personality who has developed this motor neuron disease is Steve Hawking. Right. Now, what is the pathogenesis in motor neuron disease? See, pathogenesis is mainly due to gene mutation. And what is the gene mutation? That is superoxide dismutase gene mutation. And because of this superoxide dismutase gene mutation, there will be excessive release of excitatory neurotransmitter, that is glutamate. Right, there will be excessive release of excitatory neurotransmitter, that is glutamate. And what this particular glutamate will do? This glutamate will cause the free radical damage of the motor neurons, and thereby the individual will develop motor neuron disease. Now, what is the cause of death in these patients with the motor neuron disease? The cause of death will be respiratory paralysis. Okay, respiratory muscle paralysis. So the individual will develop respiratory failure. Respiratory failure. So that is a cause of death in patients with the motor neuron disease. Now, as such, you don't have any specific drug for motor neuron disease, right? But there are certain drugs which will prevent the progression of the motor neuron disease, which will prevent the progression of the motor neuron disease. So these are the two drugs. They prevent the progression of the motor neuron disease. Now, what is the most pathognomic feature of your motor neuron disease? That will be fasciculation. Right? Now, what will the electromyography show? The electromyography, it will show you that there is degenerated nerve or degenerated muscle. Okay, and serum creatinine kinase levels will be elevated. Serum creatinine kinase levels will be elevated. Okay, so this is about your quick discussion of the motor neuron disease. And please remember, in motor neuron disease, the higher mental function will be absolutely normal. Ocular motility also will be completely spared. Okay, now let us discuss one quick clinical question. Yes, please answer this. A middle-aged man presents with progressive atrophy and weakness of hands and as well as the forearms. On examination, he is found to have slight spasticity of the legs, generalized hyperreflexia, and increasing signal in corticospinal tract on T2 weighted MRI. So what do you think is the most likely diagnosis in this patient? Yes, anyone want to make a quick attempt of this question? Right. So now if you observe this question very carefully, so this patient is having two things. Upper motor neuron features are there and as well as the lower motor neuron features are there. So what will be that upper motor neuron features? So the spasticity, that will be upper motor neuron feature. Hyperreflexia, it's an upper motor neuron feature. Then what is a lower motor neuron feature? Atrophy of the muscle, that will be the lower motor neuron feature. So the patient is having both upper motor neuron and lower motor neuron features. So what do you think will be the answer here now? The answer will be amyotrophic lateral sclerosis. The answer will be amyotrophic lateral sclerosis. Okay, so this finishes your motor neuron disease. Right now, once we are done with the motor neuron disease, Now, the next topic is multiple sclerosis. 5 minutes, I'll finish the entire multiple sclerosis. Okay, right. So, multiple sclerosis, what exactly is this? This is the demyelination of the central nervous system, where there is demyelination of the brain or brain parenchymal neuronal cells, and there will be demyelination of the spinal cord. Now, what do you understand by the word environmental multiple sclerosis? That is due to vitamin D deficiency. Then what is the virus that will be responsible for your development of multiple sclerosis? The virus that will be responsible is the Epstein-Barr virus, right? Epstein-Barr virus. And these patients, they have the HLA association. And what is that HLA association which is responsible for multiple sclerosis is, that is HLA-DR2. HLA-DR2 gene, it has been demonstrated to be genetically susceptible area. Then, what is the most common clinical pattern of the multiple sclerosis? Most common clinical pattern will be RRMS. That is relapsing remitting multiple sclerosis. Relapsing remitting multiple sclerosis. Now, what is the most common symptom in patients with multiple sclerosis? That will be the sensory symptom, and this sensory symptom will be in the form of paresthesias or sensory loss. Then, what is the most common cranial nerve which is affected in the multiple sclerosis? That is optic nerve, that is second cranial nerve. And because of the demyelination of the optic nerve, the individual can present even with blindness also. And you should know, what do you understand by the word INO? The word INO stands for internuclear ophthalmoplegia, and this internuclear ophthalmoplegia is due to demyelination of median longitudinal fasciculus. Then you need to know what is called ARP. ARP means what? That is Argyll Robertson pupil is being present. Okay, so Argyll Robertson pupil is being present. Now, what is this Argyll Robertson pupil present? Accommodation reflex. The word ARP stands for accommodation reflex present, the pupillary reflex absent. Accommodation reflex present, pupillary reflex absent. That is called as the Argyll Robertson pupil. And you should know the other conditions where you have this Argyll Robertson pupil. This Argyll Robertson pupil, please remember, it is also seen in diabetic patients. It is also seen in pinealoma, right? Also seen in sarcoidosis, right? Also seen in case of the syphilis, neurosyphilis. Okay, so these are all the conditions where you will have Argyll Robertson pupil. Then the other important characteristic pupil will be Marcus-Gunn pupil. Marcus-Gunn pupil is that where the patient will have the RAPD. What is RAPD? That is relative afferent pupillary defect. Relative afferent pupillary defect. So now, how will you demonstrate this Marcus-Gunn pupil or RAPD is by swinging flashlight test. By swinging flashlighting test, you will have the demonstration of this Marcus-Gunn pupil or the RAPD. Now, what are the other cranial nerves which are being defective apart from the second nerve? The other cranial nerves which are being defective is the fifth cranial nerve. The individual can develop trigeminal neuralgia. There can be damage to ninth and 10th nerve. That is why the individual can't drink and as well as can't speak. And there will be also damage to the 12th nerve, where the individual can't eat. That is what is the other cranial nerves which are being affected. And in this individual, cerebellum is also being affected, due to which there will be gait ataxia. There will be gait ataxia. Next is, there is also corticospinal tract involvement. Because of the corticospinal tract involvement, there can be spasticity. Right, there can be spasticity. Then paracentral lobule is also affected. So when there is involvement of the paracentral lobule, then what do you think will be the manifestation? That is, there will be urinary incontinence. There will be urinary incontinence. Okay, then coming to the Uthoff's phenomenon. Uthoff's phenomenon is that whenever the individual is exposed to heat, there will be worsening of the symptoms. That is what is called Uthoff's phenomenon. Then Lermit sign. What is Lermit sign? Lermit sign is that on bending the knee, right, on flexing the knee, there will be electric shock like sensations down the spinal cord. That is what is called as the Lermit sign. Okay. Next, then the other important point is this Lermit sign is also called as barber chair sign. Why is it called barber chair sign? Because in front of the barber you will be like folding the neck and sitting, and for which the individual can have a proper haircut. So that is why it is called barber chair sign. The other conditions where you can have this barber chair sign is Tabes dorsalis, multiple sclerosis, cervical spondylosis, syringomyelia. These are the other conditions where you can have this bar chair sign. Next, then coming to the criteria. So what is the name of the criteria? That will be McDonald's criteria. Right, that will be the McDonald's criteria. Okay, then what is the investigation of choice? The investigation of choice will be the gadolinium enhanced MRI. So gadolinium enhanced MRI will be the investigation of choice in this patient. Then what will the CSF show? CSF will show the presence of oligoclonal bands. And what will the visual evoked potentials show? Visual evoked potentials will show you that there is a decremental response in case of the multiple sclerosis. Then what is the drug of choice? Drug of choice for multiple sclerosis for acute episodes will be methylprednisolone. Right, that will be methylprednisolone. Then you take another important drug, that is, what is the drug which will cause, yes, answer this. What is the drug that causes maximum reduction in appearance of the new lesions and change in the disease severity in relapsing remitting multiple sclerosis? Yes, anyone? So that will be, no one is answering. No, it is not glatirum acetate, it is natalizumab. It is natalizumab. Okay, so that is about the drug which can cause maximum reduction in the disease severity. Next, one more important abnormality in case of multiple sclerosis is Devick's disease or neuromyelitis optica. So in Devick's disease or neuromyelitis optica, right, in Devick's disease or neuromyelitis optica, what exactly happens there is there will be more than or equal to 3 vertebral segments. There will be more than or equal to 3 vertebral segments. They undergo transverse myelitis. They undergo transverse myelitis. Along with this, there will be also severe optic neuritis. Right, there will be also development of optic neuritis. So that is what is called neuromyelitis optica or the Devick's disease. Right, so this is about your multiple sclerosis, and in multiple sclerosis you should know the images. Right, so this is the image of the oligoclonal band. Right, this is the image of the oligoclonal band. Then the next important image that you need to know here is accumulation of the fibrotic plaques within the parenchyma, and that will give you the characteristic characteristic Dawson's fingers. Characteristic Dawson's fingers. Okay, so this gadolinium enhanced MRI is considered as an investigation of choice. Right, now let us discuss about the epilepsy. Let us discuss about the epilepsy. So if you take this epilepsy, yes, can anyone tell me what is the drug of choice for your GTCS? Drug of choice for GTCS. Yes, GTCS, atonic, myoclonic or absence seizures more than 4 years. What is the drug of choice? So here the drug of choice will be valproic acid. Valproic acid. Then what is the drug of choice for febrile seizures during the episodes? Febrile seizures during the episode. Febrile seizure during the episode, the drug of choice will be intranasal midazolam or rectal diazepam. Right, then what is the prophylaxis of the febrile seizures? Prophylaxis of the febrile seizures are, that is, oral diazepam. Okay, then for absence seizures less than 4 years, the drug that you need to give is ethosuximide. Can anyone tell me why we don't give valproic acid less than 4 years? Then you should know what is the drug that we give for infantile spasm. That will be adrenocorticotropic hormone. Infantile spasms in tuberous sclerosis, that will be vigabatrin. That will be vigabatrin. Drug of choice for status epilepticus, that will be lorazepam. And drug of choice for refractory status epilepticus, that will be the midazolam. That will be midazolam. Okay, status epilepticus lorazepam, and refractory status epilepticus midazolam should be given. And if the patient is having medically refractory epilepsy, the patient is having medically refractory epilepsy, then these patients have to be advised the ketotic diet, right? Ketotic diet. And the other procedures are the nerve stimulation, that is vagal nerve stimulation. Then the other procedures that we have is the deep brain stimulation. Okay, so the best results are seen with the surgery. Best results are seen with the surgery. Okay, right. Now after having discussed about the epilepsy, now let me discuss the spinal cord disorder. Yes, anyone want to tell what exactly is the syringomyelia? So syringomyelia is what? It is a fluid filled cyst within the spinal cord, right? Fluid filled cyst within the spinal cord. Now in case of the syringomyelia, what are the tracts which are degenerated? The tracts that will be degenerated will be the spinothalamic tract, because there will be crossing of the fibers to the opposite side, and as the syringomyelia enlarges, there can be damage to your corticospinal tract as well. Now these patients, there is degeneration of spinothalamic tract and corticospinal tract. Spinothalamic tract is concerned with pain and temperature, so they will have dissociative anesthesia. What is the dissociative anesthesia? Where the individual will have loss of pain and temperature, where there is loss of pain and temperature because your spinothalamic tract is lost, and there will be intact, right? There will be intact posterior column sensations. So what will be that posterior column sensations? The posterior column sensations are like vibration sense, pressure sense, 2-point discrimination, conscious proprioception. So these are all your sensations are being intact in case of your syringomyelia. Then what is the etiology for the development of syringomyelia? The etiology is Arnold-Chiari malformation type 1, right? Arnold-Chiari malformation type 1. Then what is this Charcot's joints? Charcot's joints, these patients with syringomyelia, they have trophic ulcers and paralyzed painless joints. Right? Paralyzed painless joints. That is called as the Charcot's joints, which are seen in patients with the syringomyelia. Then what is the complication in syringomyelia? The complication that they can develop is syringobulbia, where most common site of syringomyelia will be the cervical part of the spinal cord. And once the syringomyelia progresses upwards into the brainstem, then the individual will develop syringobulbia, where there is involvement of 9th, 10th, and as well as the 12th cranial nerve. Okay, right. Then coming to the investigation of choice for syringomyelia, that will be the MRI. And what will be the treatment of choice? The treatment of choice will be decompression. Right? Treatment of choice will be the decompression. Okay, so that will be your the syringomyelia, which is right. So where you have dissociative anesthesia. Right? Now we'll move on to the next important spinal cord disorder, that is the Brown-Sequard syndrome. So Brown-Sequard syndrome, what exactly is this? It is the scenario where there is hemisection of the spinal cord. Hemisection of the spinal cord. So once there is hemisection of the spinal cord, you have motor manifestations and you have sensory manifestations. But what you have to know is, at the level of lesion, what will be the signs and symptoms? Below the level of lesion, what will be the signs and symptoms? Okay. So at the level of lesion, the motor symptoms or motor manifestations will be lower motor neuron type of paralysis. Okay. Whereas below the level of lesion, right? Whereas below the level of lesion, the motor manifestation will be, right? The motor manifestation will be upper motor neuron sign. So upper motor neuron sign will be what? That will be in the form of spasticity. That will be in the form of Babinski sign. That will be in the form of absence of involuntary movements. Next, coming to the sensory manifestations. Yeah, coming to the sensory manifestations. Sensory manifestations below the level of lesion, ipsilateral side, what sensations are being lost? Dorsal column sensations are being lost. And on the contralateral side, there will be loss of the spinothalamic tract sensations. And investigation of choice will be the MRI, and you have to treat whatever is the underlying cause for the development of the Brown-Sequard syndrome. Okay, so this is about your Brown-Sequard syndrome. Now I just show you a question on the same. Please answer this. A ventrolateral cordotomy is performed to produce relief of pain from the right leg. It is effective because it interrupts. Please answer this question. Right. So the answer in this question is very good. So you want to produce the pain relief from the right leg. So you have to do left lateral spine. So the cord, because it interrupts left lateral spinal tract. So the answer is B, right? So that was about your spinal cord disorders. Now the very important part of the discussion is the brainstem stroke syndromes. See, you don't go into a deeper depth of brainstem stroke syndromes. I just tell you in a very simple manner. First and foremost, these brainstem stroke syndromes, they will have the crossed presentations. They will have crossed presentation. What do you mean by crossed presentation? There will be ipsilateral cranial nerve involvement, contralateral corticospinal tract involvement. That is what is your brainstem stroke syndromes. What is very important here? Remember the names first. You have like midbrain stroke syndromes, pontine stroke syndromes, and medullary stroke syndromes. So midbrain stroke syndromes, that includes Weber's, Benedict's, Claude's, Perinaud's, and as well as North-Nogel syndrome. And if it is like midbrain, what cranial nerves should have been affected? Third and fourth cranial nerve. That should be ipsilateral. And contralateral, what should be gone? Contralateral corticospinal tract should be gone. So just remember this, don't go into a deeper depth. Yes, again, if you see Weber syndrome, like you have oculomotor nerve gone, corticospinal tract gone, and corticobulbar tract is also gone. And Benedict's, if you see, oculomotor nerve gone, corticospinal tract, corticobulbar tract, and red nucleus also. Don't break your head at this point of time if you did not read brainstem stroke syndromes until now. Just remember the names and cranial nerves which are affected. Then, if you take this pontine stroke syndromes, again the same story. What will be the cranial nerves in this pons? The cranial nerves that will be there in the pons will be 5, 6, and to a certain extent 7. And the 8th will be in between your pons and as well as the medulla oblongata. So you remember the names. Names are very important. Millard Gubler, Foville, Raymond Siston, locked-in syndrome. Okay, so again same story. That is ipsilateral cranial nerves and contralateral corticospinal tract involvement will be there. Okay, and what will be the cranial nerve? Any of these cranial nerve. That is 5, 6, 7, 8. Right? Accordingly, again you have the description. But one important point you need to know is regarding the locked-in syndrome. Locked-in syndrome is nothing but bilateral ventral pontine lesion. And in these patients with locked-in syndrome, you have only vertical eye movement. You have only vertical eye movement and consciousness is preserved because reticular formation is not affected in case of locked-in syndrome. So in locked-in syndrome, only vertical eye movement will be there. The remaining everything is lost. The patient will be quadriplegic. The patient is unable to speak, incapable of the facial movements. There will be a very limited horizontal eye movement, but only thing which is intact will be the vertical eye movement. That is what you see in case of locked-in syndrome. Okay, next, then you have medullary stroke syndromes. Regarding medullary stroke syndromes, two syndromes. One is lateral medullary and medial medullary. So sometimes they will ask you by the other name. This is nothing but your Wallenberg. And what are the structures which are affected in Wallenberg? That is 8th, 9th, 10th, and corticospinal tract on the opposite side. Spinothalamic tract on the opposite side. That is what you will see in case of lateral medullary syndrome. Then medial medullary syndrome. Medial medullary syndrome, the other name of it is also called Dejerine syndrome. And in medial medullary syndrome, what will be affected? 12th cranial nerve on the ipsilateral side, that is the one which is supplying to the tongue. Then corticospinal tract, which is being affected on the opposite side. Okay, so that is about your medial medullary syndrome. And in Wallenberg syndrome, the vessel that is commonly affected, in Wallenberg syndrome, the vessel that is being commonly affected is vertebral artery, followed by the posterior inferior cerebellar artery. Medial medullary syndrome, the vessel that is being affected is the anterior spinal artery. Anterior spinal artery. Okay, so this is about your brainstem stroke syndromes. So don't go into a deeper depth. Just remember the names. That is very, very important. Then cranial nerves. So midbrain stroke syndromes are Weber's, Benedict's, Claude's, Perrinot's, North-Nagel's. Pontine syndromes are Millet-Gubler, Fowell, Raymond-Seston, and Locked-in syndrome. Medullary stroke syndromes are lateral medullary and medial medullary syndrome. Okay, so that finishes your brainstem stroke syndromes, right? So I'll just ask you one quick question and let me see how many of you can answer. Yeah, lateral medullary syndrome is characterized by all except So Wallenberg syndrome, which is also called lateral medullary syndrome, please remember that Horner syndrome is present. It is not rare. The Horner syndrome is present. That is what is your lateral medullary syndrome. And giddiness will be there. Why? Because of the involvement of the vestibular nucleus of the 8th nerve. Dysphagia will be there. Why? Because of the 9th nerve. Cross anesthesia will be there because contralateral spinothalamic tract involvement will be there. So that is what is your lateral medullary syndrome, right? Now I will show you one quick question related to CVA, cerebrovascular accident, and you try to answer this. Right. A middle-aged patient presents with history of left-sided weakness for 2 days. Currently, the patient is extremely drowsy and underwent a non-contrast CT brain. Which of the following is the best treatment for this patient? Yes. So, if you observe closely the image, what is that you are having? You are having a hypodense lesion, right? You are having a hypodense lesion. That is one important thing. And yes, Prasad, in case of brainstem stroke syndromes, the cranial nerve involvement will be ipsilateral. Just keep that thumb rule. Okay, right. Now, along with this hypodense lesion, the other important feature the patient is having is the midline shift. The patient is having a midline shift. Now, so there is a midline shift with an underlying large hypodense lesion, and the history is like 2 days. History is like 2 days. So now what do you want to do in this patient? So this particular patient requires immediate decompressive surgery. Immediate decompressive surgery. Okay. So, and this large hypodense lesion is present in which area? This large hypodense lesion is present in the area of involvement of the middle cerebral artery. Okay. So, what is the history? Almost like 2 days, right? 2 days. So, can you do this thrombectomy? No. If you want to do mechanical thrombectomy, that should be done within 8 hours. That should be done within 8 hours. Now, because of the midline shift, the patient is very drowsy. So, this patient has to undergo the decompressive surgery or decompressive craniotomy. Otherwise, the drowsiness keeps on increasing where the individual get arrested as well. So, the answer is the decompressive surgery, right? Next, now after having discussed about the when to do the decompressive surgery, what is the window period for thrombolysis in a stroke patient? I think this you should not miss. This is a very simple and easy question, right? You should not miss this at all. Yes. So the window period for thrombolysis is 4.5 hours. And what are the indications for thrombolysis? Number one, the window period should be less than 4.5 hours. 4.5 hours. Okay, that is one point. Next, the other indications for thrombolysis is that the CT scan should be showing, if suppose, if the CT scan shows that there is MCA territory infarct, right? MCA territory infarct, if it is there more than one third, if it is there more than one third, then it's an absolute contraindication for thrombolysis. So it should be less than one third. To do thrombolysis, the CT scan MCA territory infarct should be less than one third. If it is more than one third, if the infarct is there, don't do thrombolysis. Don't do thrombolysis. Okay, that is very, very important point. And what should be the age of the individual? The age of the individual should be more than 18 years for doing thrombolysis, right? So this is about the story related to when you have to do thrombolysis in a patient with the ischemic stroke. Yeah, which of the following complication of the stroke need not be treated? Fever, spasticity, neglect, dysphagia. Need not be treated. Okay, so the one which need not be treated is the neglect, right? So when will the individual develop this neglect? The individual develops this neglect whenever there is blockade of the inferior division of the middle cerebral artery. Whenever there is blockade of the inferior division of middle cerebral artery, that is the point when the individual develops neglect. And this blockade of inferior division of the middle cerebral artery, if it is occurring in the non-dominant parietal lobe, if it is occurring in the non-dominant parietal lobe, then the individual will develop this neglect. Now, first of all, what do you understand by this word neglect? So the neglect means, the another terminology which can be given to this particular neglect is hemisomatognosia. That is another important terminology that can be given for the neglect. So what exactly the patient will feel? What exactly the patient will feel is that he will feel the affected limb do not belong to them. Affected limb do not belong to them. That is what is called the neglect. So even you see this, when you ask the individual to draw, you draw an image and you give it to the patient. So what he will do, he will just draw only half of the image and he will think that the remaining half does not exist. The remaining half does not exist. So the treatment of neglect is not an emergency condition. The remaining all you have to treat. Fever you have to treat, otherwise the individual will have the precipitation of the symptoms. The individual will have precipitation of the symptoms. Then spasticity, yes, it has to be treated with the skeletal muscle relaxants. And dysphagia also has to be treated, otherwise the individual will develop aspiration. So this is about like which of the following complication of the stroke need not be treated, that is neglect. Now last topic in the neurology, that is the subarachnoid hemorrhage. Yes, quickly you should answer now. So subarachnoid hemorrhage, what is the most common cause of subarachnoid hemorrhage? Most common cause of subarachnoid hemorrhage will be the head trauma. And what is the next most common cause? The next most common cause of subarachnoid hemorrhage will be the rupture of the berry aneurysm. Okay, rupture of the berry aneurysm. Then what is the most common site of berry aneurysm? The most common site of berry aneurysm is at the junction of anterior cerebral artery, at the junction of anterior cerebral artery and anterior inferior cerebellar artery. Okay, so at the junction of anterior cerebral artery and at the junction of anterior inferior communicating artery, not cerebellar artery, anterior communicating artery. I'm sorry. right? At the junction of anterior cerebral artery and anterior communicating artery, that is the most common site of berry aneurysm. Now, what will be the clinical feature? The individual will have a thunderclap type of headache. The severe headache will be there, right? Where he describes he never had in his life. And on examination, there will be neck stiffness in the patient, and there can be also the neurological deficit. And what is the investigation of choice? That will be non-contrast CT scan. And where is that? You will have the blood, you will have the blood in the sylvian fissure. You will have the blood in the sylvian fissure. The CSF analysis will show you the presence of xanthochromia. What is xanthochromia? Where the denatured RBC or the ruptured RBC will mix up with the CSF, and that will give you orange yellow in color. That is what is nothing but xanthochromia. And what is the purpose of doing angiography? The purpose of doing angiography is to look for, right, to look for the site of rupture. To look for the site of rupture. That is the point. That is the reason why to do the angiography. And then coming to the treatment in this individual. So if there is midline shift because of the hemorrhage, then you need to do decompressive surgery. If there is no midline shift, then you can give mannitol. If there is no midline shift, then you can give mannitol. Then coming to the surgical treatment, clipping or coiling and embolization. So if the subarachnoid hemorrhage is due to rupture of the berry aneurysm, then the surgical treatment that we have is the clipping or coiling and then embolization. But which is more preferred? So embolization is more preferred than compared to that of the clipping or coiling. And what are the drugs that you will give to prevent the vasospasm? The drugs that you will give to prevent the vasospasm will be nimodipine. Nimodipine is what? Nimodipine is a calcium channel blocker. Okay, now why there will be vasospasm? Because of the rupture of the berry aneurysm, the remaining vessels, they undergo compensatory vasospasm to prevent the further bleed. But once there is vasospasm in the other vessels, there can be precipitation of the cerebrovascular accident, and we don't want vasospasm to occur in the other vessels. So to prevent the vasospasm, we give this nimodipine, that is calcium channel blocker. Okay, next, then what is the indication of the ventriculoperitoneal shunt? The indications of the VP shunt is if hydrocephalus occurs, that is the point when you need to do a VP shunt. Okay, so and this is the non-contrast CT, where you have the presence of blood within the sylvian fissure, and that is the investigation of choice or first line investigation, right? And this will be the angiography. So what is the purpose of doing this angiography? That is mainly to determine where exactly is the site of rupture, right? Now the quick points related to the hemorrhage. Now whenever there is head injury, there can be epidural hemorrhage, there can be subdural hemorrhage, there can be subarachnoid hemorrhage, there can be the intracranial hemorrhage. Okay, now I want a quick answer from you all. Whenever there is epidural hemorrhage, what is the vessel that is being ruptured? What is the vessel that will be ruptured whenever there is the epidural hemorrhage? The vessel that will be ruptured whenever there is epidural hemorrhage will be middle meningeal artery. That will be middle meningeal artery. Then whenever there is subdural hemorrhage, then what is the vessel that is being ruptured? The vessel that will be ruptured when there is subdural hemorrhage will be is the bridging veins. Right, that will be the bridging veins that connects the cerebral cortex to the superior sagittal sinuses. That will be the subdural hemorrhage, the source of bleeding. Subarachnoid hemorrhage, just now we have discussed, the source of bleeding will be ruptured berry aneurysms, right? Whereas intracerebral hemorrhage most commonly caused by rupture of lenticulostriate branch of middle cerebral artery. Okay, lenticulostriate branch of middle cerebral artery. Okay, so this is about the source of the bleeding in the intracranial hemorrhages. This is a very, very important area for your questions, right? So this completes the discussion of your quick recap of the neurology, right? So I tried to cover all the important topics, and I tried to cover all the important points under the individual topic, right? So if you want to do a quick revision of this entire topic by the PDF, so you can join my Telegram channel. My Telegram channel is Medicine Made Easy by Dr. Rajesh Gubba. And if you are unable to get my Telegram channel, you can text me. I will send you the link of my Telegram channel where I'll be posting this particular PDFs for you. Right? Yeah. So I'll be posting these PDFs on my Telegram channel below. Okay. Right. So with this, I'm done with the neurology. Now the next topic is what? The respiratory system. Okay. So yes, guys, can you just give me a quick review of how was the neurology revision? So like, do you feel all the points are being covered? Like, so can anyone give me a quick review of how the session was? Right. Now, next, let me tell you, let me just give you a quick idea of the quick revision related to the respiratory system. Right. Now, if you take the respiratory system, so the topics which I have selected are the high yielding topics. Okay. So one of the very important topic is the acute respiratory distress syndrome. Acute respiratory distress syndrome. Now, what will be the clinical presentation in acute respiratory distress syndrome? The clinical presentation in acute respiratory distress syndrome will be sudden onset dyspnea. Right, that will be sudden onset dyspnea. That will be the clinical presentation. And what is the most common cause of the ARDS? Most common cause of the ARDS will be sepsis. Right, and what is the most common direct lung injury causing ARDS? That will be pneumonia. Right, and what is the most common indirect lung injury causing ARDS? That will be sepsis again. But overall, what is the most common cause? That is sepsis. Yes, Shilpa, I will take up oxygen dissociation curve. Don't worry about it. But in subsequent sessions. Now, what will be the pulmonary capillary wedge pressure in ARDS? Pulmonary capillary wedge pressure in ARDS, there will be normal pulmonary capillary wedge pressure. Right? So that will be less than 18 millimeters of mercury. Okay, and how do you measure this pulmonary capillary wedge pressure? We measure pulmonary capillary wedge pressure with the help of Swan-Ganz catheter. Now, what is the name of the criteria for ARDS? The name of the criteria for ARDS is the Berlin's criteria. So, like, you have 4 criteria. I have made a mnemonic out of it. A stands for acute in onset. A stands for acute in onset. So the sudden onset dyspnea will be within 7 days of the clinical insult. The word R stands for reduced PaO2 by FiO2. And how much that will be? That will be less than 200 millimeters of mercury. Okay. Yes, Billa. Pulmonary capillary wedge pressure is increased in left heart failure. Yes, pulmonary capillary wedge pressure will be elevated in patients with the left ventricular failure. So that is how you will differentiate cardiogenic and as well as non-cardiogenic pulmonary edema. And your ARDS is what? Your ARDS, it is non-cardiogenic pulmonary edema. ARDS is a non-cardiogenic pulmonary edema. Okay, right. Then how will you assess the severity of the ARDS? The assessment of the severity of the ARDS is mainly by your PaO2 by FiO2 value. So if PaO2 by FiO2, if it is like 200 to 300, that will be mild. And if the value is like in between 100 to 200, that will be moderate. And if the value is less than 100, then it is considered to be the severe form of the ARDS, right? That is considered to be severe form of ARDS. Now, in these patients with ARDS, there are totally 3 phases. What are those three phases? One is your exudative phase, right? One is your exudative phase. And the second important phase will be the fibroproliferative phase, right? And third important phase will be the fibrotic phase. Okay, so and in exudative phase, you have the formation of the hyaline membrane, right? You have the formation of hyaline membrane in the exudative phase, right? Next, then, and what is the treatment of choice in patients with ARDS? These patients, they have worse prognosis and they require mechanical ventilator for their support. And in the mechanical ventilator, the tidal volume that you will be using is low tidal volume. And how much will be that? 6 ml per kg. Then next is PEEP, that is positive end expiratory pressure. So how much of the PEEP that you have to use is around 10 millimeters of water. So what is the purpose of this PEEP? The purpose of the PEEP is to open the alveoli. PEEP stands for positive end expiratory pressure. And how will be the prognosis in patients with ARDS? They will have the bad prognosis. So this is about your ARDS, right? Quick. That is non-cardiogenic pulmonary edema. Okay, now how will be the X-ray in these patients with ARDS? This is the X-ray. So you have bilateral diffuse opacities. Bilateral diffuse opacities will be there, and this we describe it as bilateral white out lung. Bilateral white out lung. Okay, right now, yes. Can anyone identify this X-ray here? Can anyone identify what exactly is the abnormality in this X-ray? Yes. What will be the, or what is the abnormality in this X-ray? Yes. Right? Yes. So this is nothing but the characteristic bat wing appearance. So where do you have this bat wing appearance? That is in patients with the left ventricular failure. That is in patients with the left ventricular failure. Okay. So we are done with the ARDS now. We are done with the acute respiratory distress syndrome. Now, let me discuss the obstructive lung diseases. So among the obstructive lung diseases, one of the very important obstructive lung disease will be your COPD, chronic obstructive pulmonary disease. And there are two subtypes of the COPD. One is your emphysema, the other one is chronic bronchitis. So these are the two important subtypes in COPD. And this COPD, it is a disorder of the smaller airway. Now, what do you mean by the word smaller airways? Smaller airways means the internal diameter should be less than 2 mm. The internal diameter should be less than 2 mm. And there should be absence of the cartilage. Right, there should be absence of the C-shaped cartilaginous rings, right? And what are the other disorders which are your smaller airway diseases? The other conditions which are your smaller airway diseases are, that includes bronchial asthma, that includes hypersensitivity pneumonitis, that includes bronchiolitis, then mineral dust pneumoconiosis. So these are all your smaller airway diseases, right? Then you take emphysema. What are the types in emphysema and what will be the problem in emphysema? Emphysema, not bronchiectasis billa. Bronchiectasis is a medium-sized airway disease. I'm telling about bronchiolitis. That will be smaller airway disease. Okay, right. Then you take this emphysema. What are the subtypes of the emphysema? Right, the subtypes of emphysema, that includes the panacinar emphysema, then we have centriacinar emphysema, then we have paraseptal emphysema. Then we have paraseptal emphysema. So you take this panacinar emphysema. See, panacinar emphysema, right? Yeah, this is your panacinar emphysema. The entire acinus is abnormally, irreversibly dilated. And this panacinar emphysema is mainly due to alpha-1 antitrypsin deficiency. Then you take centriacinar emphysema. It is only the proximal part of the acinus which is abnormally irreversibly dilated. And this proximal part, this centriacinar emphysema, it is very common in smokers. It is very, very common in smokers. Then paraseptal emphysema. Paraseptal emphysema means it is only the distal part of the acinus which is abnormally irreversibly dilated. And this paraseptal emphysema, if it is ruptured, the individual will develop pneumothorax. If it is ruptured, the individual will develop pneumothorax. That is what is called as the paraseptal emphysema. Okay, so these are the types of emphysema, and the one which is hereditary and seen in alpha-1 antitrypsin deficiency will be the panacinar emphysema. Right. So that was about the subtypes of emphysema. Then coming to chronic bronchitis. See, chronic bronchitis, like what the presentation will be. See, emphysema presentation will be in the form of dyspnea. Chronic bronchitis, the presentation will be in the form of cough with mucoid expectoration. And this cough with mucoid expectoration, that will be there for nearly around 3 months, 2 consecutive years. 3 months, 2 consecutive years. Now, in these patients with chronic bronchitis, the read index will be increased. The read index will be increased. Now, what exactly is the read index? So, this is what is your read index. So, it is nothing but it is the ratio. It is the ratio of the submucosal glands, ratio of thickness of submucosal glands to that of the entire bronchial wall. Okay, it is a ratio of thickness of the submucosal glands to that of the entire bronchial wall. That is called as the reed index. And how much is the normal reed index? Normal reed index is around 0.44 plus or minus 0.09. But what will happen in chronic bronchitis? In chronic bronchitis, it is increased. It is increased up to 0.52. Why is that? Because there will be hypertrophy and hyperplasia of this mucous glands. So the numerator will be increased. So reed index also will be elevated, right? So that is about your chronic bronchitis reed index. Next, pink puffers, blue bloaters. So pink puffers, where do you come across? You come across this in patients with the emphysema. Blue bloaters, where do you come across? Right, that is in case of chronic bronchitis. Why? Because in chronic bronchitis you have the presence of cyanosis. That is the reason why they are considered to be the blue bloaters. Okay. Next, chest x-ray. Chest x-ray in patients with emphysema is very important. I'll just show you the chest x-ray and then I'll describe. So you have bilaterally hyperlucent lung fields, right? You have bilateral hyperlucent lung fields. Okay, so why? Because the lungs are abnormally irreversibly dilated. And how will be the heart in this individual? So the heart will be like a tubular heart. Why exactly is your tubular heart? Actually the heart does not turn into a tubular shape. The abnormally enlarged lungs, they overlap the heart, and that is the reason why the heart, it appears tubular. And the diaphragm, so what will happen to the diaphragm? The diaphragm will be a low set diaphragm, because this enlarged lungs will compress the diaphragm, thereby you get this low set diaphragm. Then the next important is the blebs. Next important is blebs, and these blebs, they can rupture. Once these blebs are ruptured, then the individual will develop pneumothorax. Okay, next, then followed by that the chronic bronchitis. So in chronic bronchitis, what will be the chest x-ray picture? In chronic bronchitis, there will be prominent bronchovascular markings. There will be prominent bronchovascular markings. Okay, so normally the bronchovascular markings will be there less than 1/3 in the parasternal area. If the bronchovascular markings are present more than 1/3 of the parasternal area, we call it as prominent bronchovascular markings. Okay, right. Then followed by that, you should know the treatment in these patients. So like chest x, then pulmonary function test, what it will show you? It will show you an obstructive pattern. What is that obstructive pattern? That is FEV1 by FVC will be less than 0.7. That will be your pulmonary function test. And what is the criteria for determining the severity of your COPD? That is GOLD criteria. What is this GOLD criteria? GOLD criteria stands for Global Initiative for Obstructive Lung Disease. That is what is called as the GOLD criteria, right? Now, depending upon your FEV1 value, we assess the severity of COPD. Okay, so what is that? Let me just show you. You see here, if your FEV1, if it is like more than 8 or equal to 80%, that is called mild COPD. These patients, they just require only short acting beta agonists, that's all. But if your FEV1 value is like around 50 to 79%, then it is considered to be moderate form of COPD, where we give long acting beta 2 agonists and as well as the anticholinergic drugs, right, as well as the anticholinergic drugs. Then next we have the severe form of COPD, like where the FEV1 will be 30 to 49%. So here we also add the inhaled corticosteroids. In very severe form of COPD, where FEV1 is less than 30%, then you need to give the home oxygen as well. You need to give, or you need to add long-term oxygen therapy. You need to add long-term oxygen therapy. Okay, so that is about like how you will treat the patients with the COPD, right? So you please answer this question. GOLD criteria for very severe COPD is defined as yes, it is not less than 80%. So when you are using the word very severe, it is less than 30%. and in all of them your FEV1 by FVC will be less than 70%. Okay, and your FEV1 percentage will be less than 30%. Okay, so that is about your very severe COPD. Now after having discussed about the COPD, then let me take up the discussion of another important obstructive lung disease, that is bronchial asthma. So in bronchial asthma, the patient, what do they present with? They present with dyspnea, and along with dyspnea they also have wheeze, right? And mainly it is expiratory wheeze. Now the other point is, along with the wheeze, that is along with dyspnea and wheeze, they also have cough with sputum, cough with expectoration. Now what does that sputum contain in patients with the bronchial asthma? The sputum, it contains the Kirschmann spirals. What are these Kirschmann spirals? These are spiral shaped mucus plugs. These are called Kirschmann spirals. Then what are your Crayola bodies? See, the Crayola bodies, they are nothing but ciliated columnar cells which are sloughed from the bronchial mucosa. Okay, ciliated columnar cells which are sloughed from the bronchial mucosa, right? Then coming to the charcoal laden crystals. Charcoal laden crystals, they tell you that the individual is having allergic manifestation. Okay, right. Then coming to status asthmaticus. Now what is this status asthmaticus? Yes, Billa, I will tell you respiratory failure, all the types of respiratory failure I'll teach you. Okay, right. Then coming to the status asthmaticus. So status asthmaticus, what exactly is this? It is a very severe form of acute asthma, and these patients, right, these patients, they cannot speak completely because of dyspnea. They will have this, what is called monosyllables. And what is a characteristic respiratory pattern in patients with status asthmaticus? They will have pulsus paradoxus. Pulsus paradoxus. And these patients with status asthmaticus, they develop type 2 respiratory failure, where there will be hypoxia and as well as the hypercapnia, right? And what is the drug of choice in these patients? The drug of choice in these patients will be short-acting beta-2 agonist. That is, salbutamol nebulization has to be done. And the other drug is the intravenous hydrocortisone should be given. Intravenous hydrocortisone should be given. So that is about your status asthmaticus. Then coming to brittle asthma. So brittle asthma is that these patients, despite taking appropriate therapy, the diurnal variation will be, okay, so in brittle asthma, the diurnal variation of peak expiratory flow rate will be more than 40%. That is what is called as the brittle asthma. So we have two types of brittle asthma, type 1 and as well as type 2 brittle asthma. So type 1 brittle asthma is that where there will be persistent pattern of variability and they require oral steroids, right? The treatment will be oral steroids where they will have persistent pattern of the variability. Whereas type 2 brittle asthma is that they will have normal or near normal lung function, but there will be unpredictable fall in the lung function. And that may make the individual even into death also. That is called type 2 brittle asthma. So these patients, they have to be given subcutaneous epinephrine. Type 2 brittle asthma, these they have to be given subcutaneous epinephrine. Then what is atopic asthma? That is nothing but allergic variant. Okay, where there will be increase in the IgE and where there will be also increase in the eosinophils, right? Then non-atopic asthma. Non-atopic asthma is considered to be non-allergic, and in this individual the IgE levels will be normal and your eosinophil levels also will be absolutely normal. Okay, so that is what is your non-allergic. Then what do you understand by the word drug-induced asthma? So drug-induced asthma, you mainly need to remember the NSAIDs. And these NSAIDs, what they will do, why they will induce the asthma, these NSAIDs, because they are COX inhibitors, they will increase the leukotrienes, and by increasing the leukotrienes they cause bronchoconstriction resulting in asthma. So your aspirin, diclofenac, ketorolac, they induce this drug induced asthma. Then how will you diagnose? The diagnosis is by the pulmonary function test, that is your bronchodilator response test. Now what is this bronchodilator response test? Bronchodilator response test is that in these patients with asthma or COPD, you give short acting beta agonist, then wait for 10 to 15 minutes, then you need to check the FEV1, and you need to make out how much is that increase in your FEV1. How much is the increase in your FEV1? So if the FEV1 value increases more than 200 ml before the bronchodilation, then it is considered to be bronchial asthma. Actually, the recent book has given the volume. The recent Harrison book has given the volume that is more than 200 ml. Okay, right. Then coming to your severity of asthma. So how will you assess the severity of asthma? Like how will you assess is that is based on your FEV1 value itself. Okay, so if FEV1 is like more than 70%, we call it as mild form of asthma. If the FEV1 is around 40 to 69%, we call it as moderate form of asthma. If the FEV1 value is less than 40%, we call it as severe form of asthma. And if the FEV1 value is less than 25%, we call it as very severe form of asthma. Right, we call it as very severe form of asthma. Okay, right. Then finally, how do you treat these patients with asthma? The treatment is that drug of choice for acute attacks will be short acting beta agonist, and drug of choice for prophylaxis will be mast cell stabilizers, right? Mast cell stabilizers and leukotriene antagonists. Okay, so that will be your drugs that we give for prophylaxis. Okay, right. And yes, Rachna, sir, in ABG analysis, can you tell when there will be compensated and when there will be decompensated? Okay, or when there will be non-compensated, right? So this is actually a separate topic. Let me just give you 1 minute idea. So when do we use the word compensated is, like for example, your bicarbonate and your CO2, both of them have changed. Okay, they are not in the normal value, both of them have changed, and they have changed equally in same direction, then the pH will get normalized. That we call it as compensated. Then we use the word compensated when both of them have changing equally in the same direction, and because of this change the pH has been normalized, then we use the word compensated. Then you take other scenario, bicarbonate increased, carbon dioxide also increased, but it is more increased. pH is abnormal because both of them did not change equally. When pH is abnormal in spite of the change, this we call it as uncompensated. This we call it as uncompensated. Okay, so ABG definitely it's completely a separate topic, right, which I'll take it depending upon the time availability and time permits. Right, now the next important topic for the quick revision is the cystic fibrosis. Okay, so if you take the cystic fibrosis, this is also an obstructive lung disease, and the type of inheritance will be autosomal recessive type of inheritance. The gene which is being mutated will be the CFTR gene that is being mutated, and this CFTR gene is present on chromosome 7. What will be the abnormality is the deletion of, right, deletion of phenylalanine on 508 position. Okay, say everyone is aware CFTR gene, everyone is aware chromosome 7, everyone is aware 508 position, but in the recent INA-CT exam the amino acid has been asked, that is phenylalanine, deletion of phenylalanine at 508 position. Okay, so then what will be the neonatal presentation? The neonatal presentation in case of cystic fibrosis will be in the form of meconium ileus. And how do you treat this meconium ileus? You have to give gastrographin enema, right? Gastrographin enema. Then what is the most common cause of death in patients with cystic fibrosis? These patients, they will have recurrent pneumonias, and because of recurrent pneumonias they will develop respiratory failure. Because they develop respiratory failure, they will have death. That is the most common cause of death in patients with the cystic fibrosis. Now, what will be the lung involvement in patients with cystic fibrosis? There will be bronchiectasis, right? Which lobe is affected? The upper lobe is being affected. Okay. Then what will be the GIT manifestations? GIT manifestations in patients with cystic fibrosis will be in the form of secondary biliary cirrhosis, right? And not only that, these patients also will develop osmotic diarrhea. This will be the GIT manifestation, cystic fibrosis. And both males and females, they suffer with infertility. And in males, the reason for infertility will be azoospermia, right? Azoospermia. And this azoospermia is caused due to agenesis of the vas difference. And in females also, they will have infertility with cystic fibrosis. That is because of increased cervical mucus thickness. That is because of increased cervical mucus thickness. Then coming to the investigations, if you do a sweat chloride test, the sweat chloride test will show you that there is more than 60 milliequivalents per liter of the sweat chloride, right? Normally it is up to 30 to 40. But here, the sweat chloride concentration will be more than 60 milliequivalents per liter on 2 occasions. But what is the investigation of choice? You have to do the genetic analysis. Okay, so where you will understand that there is CFTR mutation has occurred. Then what are the targeted therapies? The targeted therapies for your CFTR, that is for cystic fibrosis, is you should give CFTR trafficking drug. What will be that particular drug? That drug is ivacaftor. Okay, and this ivacaftor, it is a potentiator of CFTR channel, and that works by increasing the time the channel remains open after being activated. And we have other drugs also, that is lumacaftor, then tizacaftor, then elixacaftor. These are the other drugs which are your targeted therapies. Then when the lung involvement is diffuse, when the lung involvement is diffuse lung involvement is there, then you need to do the lung transplantation. Okay, so this is about your cystic fibrosis. Quick revision, right? The next topic for the revision will be the bronchiectasis. The next topic for the revision will be bronchiectasis. So bronchiectasis is also an obstructive lung disease, and it is a disorder of the medium-sized airways. So which particular airways are affected here? It is 5th to 9th generation, right? 5th to 9th generation is being affected in bronchiectasis. And what is the most common lobe which is affected in bronchiectasis? That is the left lower lobe, followed by that the middle lobe. And which middle lobe? That will be the right middle lobe. Okay, then depending upon the shape, which is the most common type of bronchiectasis? The most common type of bronchiectasis will be cylindrical bronchiectasis, right? What are the conditions where you will have the upper lobe bronchiectasis? Upper lobe bronchiectasis, you have that in case of tuberculosis, cystic fibrosis, and allergic bronchopulmonary aspergillosis. Then what are the conditions where you have mid-lung bronchiectasis? That you have in case of Mycobacterium avium infection and even immotile cilia syndrome. Lower lung bronchiectasis, it is mainly seen in case of chronic recurrent aspiration. Right, chronic recurrent aspiration, you have this lower lung bronchiectasis. Central bronchiectasis is seen in patients with the allergic bronchopulmonary aspergillosis and as well as the cystic fibrosis, right? Then on examination, what is that you will have in patients with the bronchiectasis? On examination, there will be clubbing, and along with the clubbing, there will be leathery crepitations. Right, there will be leathery crepitations. That is what you will have in case of the bronchiectasis. Then what is the investigation of choice? That will be the HRCT. Right, the investigation of choice will be the HRCT, right? And what will the chest X-ray show? Chest X-ray will show you the classical tram track appearance in case of the bronchiectasis. And what is the treatment? See, these patients, they have thick mucoid sputum, right? They are associated with thick mucoid sputum. So thick mucoid sputum, like what is that you have to do? You have to give the drugs which will, or substances which will liquefy the sputum, or chest physiotherapy you have to do. When by doing the chest physiotherapy, like you will see that the entire sputum is expectorated out. Then coming to the one of the very important complication in bronchiectasis is massive hemoptysis. So whenever there is massive hemoptysis, like the treatment that you will do is bronchial artery embolization. Bronchial artery embolization. Okay. Yes, Rachna. Smoking is associated with small cell carcinoma. Smoking is associated with squamous cell carcinoma. Smoking is associated with large cell carcinoma. Right. And in non-smokers, the type of bronchogenic carcinoma that you will have is adenocarcinoma. Okay. Right. So that is about your smoking and as well as this thing. Now, let me just show you some of the important images related to the bronchiectasis. So you see here, this is the very important image. So they'll have this three-layered sputum in case of the bronchiectasis, because these patients, they'll have copious amount of sputum, and when you collect this sputum in a flask and you just keep it aside, you will get this three-layered sputum. So where you have the presence of the foam, the upper layer, the middle layer, like you have the mucopurulent material, right, and the lower layer will be completely pus. So this is what is called as the three-layered sputum that you get in case of the bronchiectasis. Then now coming to chest x-ray. So chest x-ray is not very much important investigation to give you the diagnosis of bronchiectasis, but you get this classical tram track appearance. Classical tram track appearance, which is nothing but your railway track appearance. Okay, right. Then what is the investigation of choice we have discussed? That is the HRCT. So HRCT will give you tree in bud appearance. That is in case of cystic bronchiectasis. Right, that is in case of the cystic bronchiectasis. Now, one more important sign in bronchiectasis will be the signet ring sign. One more important sign will be the signet ring sign. Okay, so this is about your quick revision of the bronchiectasis. Right now, yes, please answer. Now we'll discuss few important quick points related to bronchogenic carcinoma. So clubbing is least common in which type of bronchogenic carcinoma? So clubbing, not adenocarcinoma, clubbing is least common in case of the small cell carcinoma. Right, it is least common in case of the small cell carcinoma. Right, now let me just tell you some quick points related to bronchogenic carcinoma. So the most common benign tumor of the lung, that will be hamartoma. Right, hamartoma will be the most common benign tumor. And what is the most common cause of recurrent hemoptysis? That will be bronchial adenoma. And among all the cancer deaths, what is the most common cause of the cancer death? The most common cause of cancer death will be the lung cancer. Right, and what is the most common risk factor for the development of bronchogenic carcinoma? That will be smoking. What is the most common natural risk factor for the development of bronchogenic carcinoma? That will be exposure to the radon gas. What is the most common rib destroyed in Pancoast tumor? That will be the first rib. Now the question is, which type of bronchogenic carcinoma can make the individual to develop the Pancoast tumor? Yes, which type of bronchogenic carcinoma will make the individual to develop the Pancoast tumor? Any one of you? So this Pancoast tumor is very commonly seen in case of adenocarcinoma. So adenocarcinoma, that is an increased risk of development of your Pancoast, right? Very good, Priya Thakur. So, and what is the most common nerve roots which are involved in Pancoast? Most common nerve roots which are involved in Pancoast will be C8, T1 and as well as T2. C8, T1 and as well as T2, right? And if the question is asked, what is the most frequent histological type? Most frequent histological type will be adenocarcinoma. But what is the most frequent histological type in India? In India, it will be squamous cell carcinoma. In India, it will be squamous cell carcinoma. And what is the most common histological type in non-smokers? That will be adenocarcinoma. And most common histological variety in young patients, that will be also adenocarcinoma. In females, that is also adenocarcinoma. And what is the most common site for metastasis from carcinoma lung? That will go to the liver first. But whereas if the question is asked endocrine organ, most common endocrine organ to be involved by metastasis of the carcinoma lung, that will be the adrenals. Right, that will be the adrenals. Okay, right. Then next is carcinoma lung that will metastasize to the opposite lung, that will be adenocarcinoma. That will be adenocarcinoma. And most common tumor to metastasize to the heart, that will be carcinoma lung. Okay, so actually from carcinoma lung, the most common organ where it will go metastasis is to the liver. But to the heart, where it will receive the metastasis most commonly from, that will be from carcinoma lung. Right? And histological varieties that cavitate. The histological variety that will cavitate is squamous cell carcinoma and as well as large cell carcinoma. Right? And histological variety that is like central in distribution, that will be squamous cell carcinoma and even small cell carcinoma. Peripheral in distribution, that will be adenocarcinoma. Peripheral in distribution will be adenocarcinoma, right? Then what is the most common variety associated with paraneoplastic syndrome? That will be small cell carcinoma, right? That will be small cell carcinoma. Okay, then followed by that, yes, most common type of bronchogenic carcinoma associated with hypokalemia. Most common variety associated with hypokalemia. Yes, right, that will be small cell carcinoma. Why is that? Because small cell carcinoma will be the source for ectopic ACTH, and this ectopic ACTH will produce steroids, and these steroids will activate the ENaC channels that will cause sodium and water retention, potassium excretion, and H plus ion excretion. So that will result in the hypokalemia, right? And most common variety associated with hypercalcemia, that will be squamous cell carcinoma. That will be squamous cell carcinoma. And histological variety, why is that squamous cell carcinoma? Because this squamous cell carcinoma will release parathormone related protein. So that is the reason why that will cause hypercalcemia. And histological variety most responsive to chemotherapy, that will be small cell carcinoma. Right? Response to radiotherapy, that will be also small cell carcinoma. And the histological variety with best prognosis, that will be squamous cell carcinoma. That will be squamous cell carcinoma. Okay, so and two important questions that you have more on bronchogenic carcinoma is about the tumor markers. So what will be the tumor markers? So we have two important tumor markers. One is your carcinoembryonic antigen, the other one is the neuron specific enolase. So you take this carcinoembryonic antigen. Carcinoembryonic antigen, it is the tumor marker for metastatic cancer. Right, it is a tumor marker for metastatic cancer. Then we have neuron specific enolase. Neuron specific enolase, it's a prognostic marker. Right, it is a prognostic marker in small cell carcinoma. Right, and what will be the presentation in case of bronchogenic carcinoma? The individual will have cough with copious expectoration, which is serous in consistency. They'll have loss of appetite, loss of weight. That will be the classical presentation in patients with the bronchogenic carcinoma, right? Now, so that was about the topics related to bronchogenic carcinoma. One important point that you people were asking me about the respiratory failure. Now, if you take this topic of respiratory failure, so we have type 1, type 2, type 3 and type 4 respiratory failure. So you take this type 1 respiratory failure. Type 1 respiratory failure, it is acute hypoxemic respiratory failure. Right, acute hypoxemic respiratory failure. Okay, and that is due to alveolar flooding. That is due to alveolar flooding. So this type 1 respiratory failure, you will have hypoxia. Carbon dioxide levels will be normal or reduced. Okay, so that will be your type 1 respiratory failure. Type 2 respiratory failure is due to alveolar hypoventilation. This will be alveolar hypoventilation, where there will be hypoxia and there will be hypercapnia. Then one more important parameter that will differentiate these two will be A ratio. That is alveolo-arteriolar oxygen gradient. Alveolo-arteriolar oxygen gradient. In case of type 1 respiratory failure, the AA gradient will be increased. Whereas in type 2 respiratory failure, the AA gradient will be normal. The AA gradient will be normal in type 2 respiratory failure. Then what is this type 3 respiratory failure? It is perioperative respiratory failure. Right? Perioperative respiratory failure, where there will be lung atelectasis. Right, immediately after the surgery, the individual will not recover back from the general anesthesia. That is what is called perioperative respiratory failure, where there will be lung atelectasis. Then coming to your type 4 respiratory failure. So type 4 respiratory failure, it is due to cardiogenic shock. Right, that is due to cardiogenic shock. Okay, so cardiogenic shock, like what happens is the respiratory muscles, they receive they receive less than 5% of the cardiac output. That is what is normal. But once there is cardiogenic shock, the respiratory muscles, they don't receive the adequate amount of blood supply and they get paralyzed. That is what is your type 4 respiratory failure. Okay, so this is about the 4 important types of the respiratory failure: type 1, type 2, type 3, and as well as type 4. So in type 1 you have hypoxia and carbon dioxide levels will be normal or reduced, and in type 2 you will have hypoxia, hypercapnia. Type 3 it is perioperative respiratory failure, and type 4 it is secondary to the cardiogenic shock. So this is about your types of the respiratory failure. Now we'll see some quick questions. Right, 1 minute. Yes, answer this. D-dimer values may be increased in all of the following conditions except. So this is like a question related to Priya Thakur. Muscle weakness will be there in all the 3. Type 2 also you can have muscle weakness. Type 3 also you can have muscle weakness. Type 4 also you can have muscle weakness. Okay, so muscle weakness is there in all your 2, 3, 4. But the only thing is the etiopathogenesis, the etiology is different. Right. So D-dimer value may be increased in all of the following conditions except what? Anticoagulant therapy. See, when the patient is on anticoagulant therapy, what is D-dimer? D-dimer is a fibrin degradation product. D-dimer is a fibrin degradation product. So when the patient is on anticoagulant therapy, where is the question of the clot formation? Clot formation will not be there. So because there is no clot formation, the D-dimer value will not be elevated when the patient is on anticoagulant therapy. So the answer is 3 here, right? So, and that was actually the questions related to pulmonary embolism, which already we have discussed. Yes. Please tell me in which condition you will have this abnormal chest X-ray. Yes, in which condition you will have this abnormal chest X-ray. So what is that you are finding? There is like bilateral hilar lymphadenopathy. So this is a classical X-ray of sarcoidosis. It is not tuberculosis, Amit. In tuberculosis, you will have unilateral hilar lymphadenopathy. It is in sarcoidosis where you will have bilateral hilar lymphadenopathy, right? Then, yeah, what is the skin manifestation in sarcoidosis? What is the skin manifestation in sarcoidosis? So this is what is nothing but your yes. So this is lupus pernio, where you have the purple blue color which is present over the malar eminences, over the nose, and even over the lips. You'll have this. This is what is nothing but lupus pernio, and this becomes a very close differential diagnosis for the malar rash of the SLE. Okay. Yes. What is the skin abnormality in sarcoidosis? What is the skin abnormality in sarcoidosis? Right, so this is nothing but where you have inflammation of the subcutaneous fat. So this is nothing but erythema nodosum. You can see here, this is what is nothing but erythematous patches. This is what is nothing but erythema nodosum. right? And yes, so in Garland's triad, right, which all lymph nodes are abnormally enlarged? Which all lymph nodes are abnormally enlarged? Okay, so that will be the individual will have bilateral hilar lymphadenopathy. Along with that, there will be right paratracheal lymphadenopathy. There will be also right paratracheal lymphadenopathy, and this is what is called as 1 2 3 sign or the Garland's triad. Then you should know the gallium uptake studies. In sarcoidosis, you should also know the gallium uptake studies. So if you see this gallium uptake studies, right, so we have the two important signs. One is your panda sign. So panda sign is due to increased gallium uptake within the lacrimal glands, right? Then you have lambda sign, that is due to increased gallium uptake within the lymph nodes. Okay, so this will be the gallium uptake studies. Then overall in patients with sarcoidosis, then what will be the investigation of choice in sarcoidosis? What will be the investigation of choice in sarcoidosis? The investigation of choice in patients with sarcoidosis will be biopsy. So when you do a biopsy, that will show you the presence of non-caseating granuloma, right? That will show you the presence of non-caseating granuloma. So that is what is the biopsy picture in these patients, right? Then what is the drug of choice in patients with sarcoidosis? What is the drug of choice in patients with the sarcoidosis? So see, your sarcoidosis, which is a multi-system disorder, it is due to abnormal immune reactivity. So drug of choice is you should give the immunosuppressant agent, that is corticosteroids. Okay, prednisolone is considered as drug of choice. But in those individuals who are having corticosteroid refractory disease, need to give alternative drug. That alternative drug will be methotrexate, or we have other alternative drug, that is azathioprine, or infliximab should be given, right? Infliximab should be given. Okay, so this is about like the treatment what you will give in case of the corticosteroid refractory disease, right? So these are some of the important topics related to the pulmonology, right? Now after having, okay, one quick question, please answer this. Yes, all of the following types of respiratory failure, all of the following types of respiratory failure, they are correctly matched except, all of the following types of respiratory failure are correctly matched except, yes, which is the incorrect statement here. Very good, Priya Thakur. So that is type 4. So type 4, what did we discuss? It is secondary to cardiogenic shock, right? Secondary to cardiogenic shock. Okay, right. Yes, type 3, it is your perioperative, where there will be atelectasis of the lung, where there will be collapse of the lung, where there will be collapse of the lung. Okay, right. And the next important is, yes, in ICU setting, patients suffering from which of the following respiratory pathology is most predisposed for carbon dioxide narcosis? Is most predisposed for carbon dioxide narcosis? Anyone? No. So no. See, all these will lead to type 1 respiratory failure. All these will lead to type 1 respiratory failure, where carbon dioxide levels will be reduced or it may remain normal. You take this motor neuron disease. Motor neuron disease, we have discussed in the neurology, we have revised in the neurology. The cause of death in these patients will be respiratory failure. The cause of death in these patients will be respiratory failure. And what type of respiratory failure? Type 2 respiratory failure. So where the individual will have hypercarbia causing carbon dioxide narcosis. So the answer is A, that is motor neuron disease. It is not your emphysema, it is not even your bronchiectasis as well, right? So with this, we are done with the pulmonology, right? Now in the gastroenterology, I'll not go into the depth of the gastroenterology because most of it you will be covering in the surgery, but I'll try to discuss this viral hepatitis. I'll try to quickly revise the viral hepatitis. Okay, so viral hepatitis is one important area in the gastroenterology medicine where the questions will be asked very frequently. Okay, now tell me, right? Tell me, most common virus associated with transfusion associated hepatitis. Most common virus associated with transfusion associated hepatitis. So that will be in another 10-15 minutes. I'll wind up the session. So the most common virus associated with transfusion associated hepatitis will be, that is the hepatitis B virus. Okay, and among all these viral hepatitis, that is A, B, C, D and E, which particular viral hepatitis the vaccine or prophylaxis is not available? That will be for hepatitis C virus. That will be for hepatitis C virus. Okay, right. Then you take the malignant potential. Malignant potential is present with, so malignant potential is highest with hepatitis C virus, then followed by that the hepatitis B virus. Okay, then progression to chronicity. Progression to chronicity is seen with which particular viral hepatitis? That is hepatitis B and as well as the hepatitis C virus. And you take this perinatal transmission, that is from mother to fetus. It is seen with B, C and D. But perinatal transmission is most significant with hepatitis B virus, right? And this, what are the viral hepatitis which are being spread by parental route? That will be B, C and D. So that means they are being spread by the percutaneous or intravenous or pinprick and sexual transmission and then vertical transmission. Okay, whereas the viral hepatitis which is being spread by non-parental route, that means it is nothing but the fecal-oral route. So what is that? That will be your hepatitis A and as well as the hepatitis E. They are like non-parental route. Okay, then you have few more questions on the same viral hepatitis. Hepatitis B is not transmitted through, please remember this, it is not transmitted through the fecal-oral route. And most common hepatitis that will progress to chronicity, it will be, I said you both, actually it is hepatitis C more than compared to the hepatitis B. Okay, now this question is very important. Most common cause of the fulminant hepatitis in pregnant women. Any one of you? Most common cause of the fulminant hepatitis in pregnant women. Most common cause of fulminant hepatitis in pregnant women will be the hepatitis E. And most common cause of epidemic hepatitis, most common cause of epidemic hepatitis is also the hepatitis E. And what is the most common cause of sporadic hepatitis in adults? That is also the same. Most common cause of sporadic hepatitis in adults, that will be again the hepatitis E. And most common cause of sporadic hepatitis in children, that will be hepatitis A. Okay, so this is about the story related to the important points related to viral hepatitis. Now I'll just show you one clinical scenario. Please answer this. So a 30-year man presented with nausea, fever and jaundice of 5 days duration. The biochemical test revealed the bilirubin of 6.7 milligrams per deciliter, SGOT, SGPT touching the sky, right? They are elevated. The serological test shows the presence of surface antigen, IgM anti-HBC, envelope antigen. What is the most likely diagnosis in this patient? What is the most likely diagnosis in this patient? Right, so now you have an options, Priya Thakur, please tell me. Acute hepatitis B, there are two options. Right, good. So that will be acute hepatitis B with high infectivity. Right. So why am I using the word acute hepatitis B? Because IgM anti-HBC is positive. Why am I using the word high infectivity? Because envelope antigen is positive. So presence of envelope antigen, high infectivity. Presence of IgM anti-HBC, that is acute hepatitis. Okay, right. Then presence of the surface antigen. See, if surface antigen is positive, the individual, you can call it as either acute, you can call it as either chronic, or the individual is in carrier stage. The individual is in carrier stage. So that is what is your, the presence of surface antigen, either it is acute or chronic or carrier stage. Any of these can be there. That is what is your surface antigen if it is present. All right. Then what are the markers of the infectivity? That is envelope antigen. Whereas if the individual is having anti-HBE, what does that tells you? That is low infectivity. That is low infectivity. Okay, right. Then what is a marker of replication? Any one of you? What is the marker of the replication? The marker of the replication is, yeah, so when there is anti-HBE, that is low infectivity. Right. So marker of the replication will be HBeAg, that is envelope antigen, HBV DNA, that is also a marker of replication, and the presence of DNA polymerase. Right, presence of DNA polymerase. Okay, so these are the markers of the replication. But which is the definitive marker? The definitive marker of viral replication, that will be DNA polymerase. The definitive marker of your viral replication will be the DNA polymerase. Okay, so your HBeAg, this is considered as qualitative marker. This is considered as the qualitative marker. But whereas the HBV DNA and DNA polymerase, they are considered to be quantitative markers. They are considered to be quantitative markers. Okay, right. Then you should know the treatment of the hepatitis B. Yes. So a young man presents with surface antigen positive, anti-HBC IgG positive, envelope antigen negative, normal levels of AST and ALT. He is asymptomatic. What is the next line of management? What is the next line of management? So surface antigen is positive, IgG positive, that means it is chronic. Envelope antigen negative, that means low infectivity. Normal AST, normal ALT. Right. So what is the next line of management is, in this patient we don't start the antiviral drugs. In this patient we wait and watch. Now what is the indication for starting the antiviral drugs? See, what are the first line antiviral drugs? The first line antiviral drugs will be, just remember this mnemonic, PET. What does this PET stands for? That is pegylated interferon. E stands for entecavir. T stands for tenofovir. Right, T stands for tenofovir. So these three are your first line antiviral drugs. Now what is the indication to start the antiviral drugs? Okay, so once you get the surface antigen being positive, and once you find that IgG anti-HBC is positive, see, we give antiviral drugs only in chronic. We don't give antiviral drugs in case of acute. We don't give antiviral drugs in acute. We give antiviral drugs only in chronic. Okay, so now once you find that it is a chronic hepatitis B, then you have to check for the HBV DNA levels. You have to check for the HBV DNA levels. So what is the latest data is that if the HBV DNA levels are more than or equal to 2 into 10 to the power of 4 DNA copies are there per ml, then you should start the treatment. Then you should start the treatment. And along with that, your SGPT value should be elevated 2 times. Right, your SGPT value should be elevated 2 times. Okay, so that is about the indications for treatment. So your HBV DNA levels should be more than or equal to 2 into 10 to the power of 4 DNA copies per ml, and SGPT value should be elevated more than 2 times. That is the indication to start the antiviral drugs. So in our patient, your AST and ALT is normal and your DNA copies have not been mentioned. So don't start any antiviral drug in this patient. So you have to just wait and watch in this patient. Antiviral drugs is not indicated, right? Then quick revision of the hepatitis C. Quick revision of the hepatitis C. So hepatitis C, what did I tell you? That is being spread through parenteral route, either pinprick or subcutaneous or intravenous, vertical transmission, and then sexual transmission. Okay, but what is the most common mode of transmission of hepatitis C? Most common mode of transmission of hepatitis C will be percutaneous route, right? Percutaneous route. And this hepatitis C does not spread through fecal-oral route. And for hepatitis C, as already I have mentioned, there is no vaccine. There is no vaccine or the prophylaxis. But this hepatitis C, it has the highest malignant potential. Among all the viral hepatitis, the hepatitis C is having the highest malignant potential. And if you take the antibodies for your hepatitis C, the antibodies are anti-LKM antibodies. The antibodies are anti-LKM antibodies. Okay, so what is that anti-LKM? That is the antibody which is directed against liver, antibody which is directed against kidney, the antibody which is directed against the kidney microsomes. That is what is your anti-LKM antibodies. And again, these anti-LKM antibodies also, we have again three types: anti-LKM1, anti-LKM2, anti-LKM3. In case of chronic hepatitis C, the type of anti-LKM antibodies that we have is anti-LKM1, right? Anti-LKM1 antibodies are present in case of the hepatitis C, right? Then coming to the treatment, so when you have to treat, right, and what are the antiviral drugs, let me just tell you. So what is the indication for treatment for your viral hepatitis? Okay, so you have to check, once you find that the antibodies are there, you have to check for the HCV RNA levels, and you have to look whether these HCV RNA levels, whether they are elevated or not. Okay, now along with elevated HCV RNA levels, you have to check the ALT, that is the enzyme, whether there is elevated ALT or normal ALT. If there is elevated ALT along with antibodies and HCV RNA, then you have to treat without doing liver biopsy. But if there is normal ALT, then you have to perform liver biopsy to obtain the histological diagnosis and then staging of chronic hepatitis. And if you want to treat, then what is the drug that we give? For genotype 1 of HCV, right? For genotype 1 of HCV, the drug of choice will be ledipsavir, right? The drug of choice will be ledipsavir. And for genotype 2, right, for genotype 2 of hepatitis C virus, then in this case, the drug of choice will be sofosbuvir, right? Sofosbuvir, plus we also give ribavirin, right? We also give ribavirin. Okay, so that is what is the treatment for your hepatitis C virus. The one which is having the highest malignant potential and highest tendency for chronicity will be your hepatitis C virus, right? So this completes the quick discussion of your viral hepatitis, right? So with this, I'm done with even GAT also. GAT, very important part in the medicine part is your viral hepatitis. The remaining part and all, you might have been revised or you might have read in the surgery part itself. So I'm not going to touch that, the peptic ulcer disease, carcinoma stomach, the inflammatory bowel disease, all that which you have read in your surgery, right? So with this, I'll wind up this particular session. And as I have said you, now immediately after the session is over, I'll just send this PDF on my Telegram channel. And those students who are unable to get my Telegram channel, so you can just text me on my WhatsApp number, that is 9686241211. So I'll be sending you my Telegram channel link where you can join and download the PDF. And these PDFs will definitely be useful for your upcoming FMGE exam. Not only that, even for the NEET PG exam. So I have quickly try to recap all the topics of the entire medicine. The hematology, I did not touch that because that is another important area where you have integration with the pathology. So pathology you might have been revised or you might have read. So that is the reason why I did not touch even the hematology as well, right? So with this, I will wind up this session and I wish you all the best for your upcoming FMG exam. So don't take a lot of stress in this last 3 days, right? Be confident by yourself. Be hopeful that you will definitely clear the exam. So taking too much stress, right, this will hamper the complete preparation whatever you have done in the last 5-6 months. So be confident enough that you will definitely clear. Okay, so thank you very much and I wish you all the best for your exam.